All right, welcome everybody. Welcome to the final session of the Society for Academic Emergency Medicine's Consensus Conference, From Bedside to Policy, Advancing Social Emergency Medicine and Population Health Through Research, Collaboration, and Education. I'm Elizabeth Schoenfeld. I'm one of your co-chairs for the Consensus Conference. And again, I will be putting all of the co-chairs' email addresses in the chat so that you can contact us at any time about anything. Obviously, we're not going to respond to our email in the middle, but you'll have it for later if there's any comments or issues that come up. All right. If you are unable to attend either of the previous sessions on April 13th or April 27th, those recordings are available through SAEM. And all you have to do to get the link for those is to just drop an email to consensus@saem.org, and that is also in the chat if you will want to receive that link.
Thanks again for joining us. I'm Maggie Samuels-Kalo, another one of the co-chairs of the Consensus Conference. Our first two sessions focused on developing research priorities for social emergency medicine, and today's session will help us build the collaborations to move those priorities forward. We will first listen to brief summaries from the leaders of the breakout sessions that happened at the last two meetings. Then we will move to discuss projects in progress. For the first sessions of projects in progress, you will get to choose from 3 different topics. And within that topic, you will hear from about a half a dozen presenters about different ongoing projects. After a break, we'll move into our second session, and you'll be able to choose from 2 different projects to talk about. After another short break, we'll move into our final keynote of the Consensus Conference. Dr. Joné Khaldoun will give us her presentation, Policy, Public Health and Medicine, Practical Approaches to Improving Public Health.
Hi, everyone. I'm Michelle Lynn. I'm another one of the co-chairs of the Consensus Conference. Welcome. Before we hear from our breakout group leaders, I do want to give you some background on how you're going to select your projects in progress sessions. Some of you are going to be joining via Zoom, and some are going to be joining via Juno. If you have a newer version of Zoom, you may be able to select your session on your own. If you don't see that option, please change your name to the letter corresponding to the session that you would like to join. These are listed in the agenda on the screen. They are also going to be dropped into the chat momentarily. They are going to be A, identity and health, people and places, B, healthcare systems, C, education and training, and those are for the first session. So you choose A, B, or C now. We're going to reconvene for a break, and then at that time, you can assign yourself D or E, or you can put both in right now. All of those sessions are going to be projects in progress, so we're going to hear from various people talking about local projects and specific barriers and challenges that they've faced. And then and for those of you who are designated speakers, you're going to have co-hosting privileges. If for some reason that doesn't work, please come back to the main room and we can address that issue. So we won't be leaving the screen for another couple minutes, but I just wanted to give everyone a heads up so that they can make those selections by changing their name if they would like. We're now going to hear from the breakout group leaders about the work that's happened over the past 9 months and at the last 2 consensus conference sessions in April. I'm going to have the leaders from these groups introduce themselves. We're also going to post the survey links for the research agenda that arose from those 2 sessions for those who have not yet had an opportunity to share their input on the research agenda. So those are going to be dropped into the chat momentarily. So without further ado, we will move on to group 1.
Great. Thank you, Michelle. And thanks for the Consensus Conference leaders for all your leadership in this. My name is Kaylin Folkley, and I am the Population Health Research Fellow in the Department of Emergency Medicine at the University of Washington. I co-led the Screening for Social Risks and Needs in the Emergency Department breakout session with Herbie Duper, who is an associate professor and section head for population health at the University of Washington. However, we represent an amazing team who worked tirelessly to ensure the success of our breakout group. A special thanks to Kelly Duran, Rochelle Cooper, and Michelle Lynn from the leadership team, objective leads Jackie Furbacher, Pyle Modi, Mackenzie Yor, Nick Gavin, Lilia Kranoff, and Ewan Wang, and our external experts from ASPE, Siren, and Health Leads. Could you advance to the next slide? Awesome. So our group sought to define a research agenda based on literature gaps and expert opinion in the following areas. First, instruments used for social risk and needs screening in the ED. Second, implementation of social risk and needs screening in the ED. And third, interventions for patients with social risks and needs in the ED. Next slide. So we started this work by first identifying search terms through the assistance of a health sciences librarian. 2,085 articles were found in a PubMed search, and 151 relevant articles were identified after reviewing the titles and abstracts. We did a supplemental search with the Siren Evidence and Research Library and a subsequent snowball literature review. A small group of individuals were assigned to our 3 objectives, reviewed the assigned articles, and filled in the analysis matrix. The literature was then synthesized, and this information was shared with our external experts. Their feedback was incorporated into the pre-reading document that was shared with our breakout group participants. Lastly, the consensus conference allows us to have a moderated discussion about all the research priorities as a group, receive qualitative and quantitative feedback during the intersession survey, facilitate focused discussions about each objective through 3 breakout groups, and finally, have participants rank research priorities based upon their priority for future research and the SMART, or specific, measurable, attainable, relevant, and time-based criteria. Next slide, please. So the Objective 1 research priorities highlighted the role of theoretical models like social determinants of health in informing screening instruments, the pertinence of certain domains of social risks and needs to social emergency medicine, the role of universal screening, the validation of existing screening tools, and finally, the need to incorporate community partners, patients, and key stakeholders in developing or modifying existing screening tools. Objective 2 emphasized the mechanics of implementing social risk and needs screening, including when, where, by whom, and how it should be done, the role of technology, for example, chatbots, kiosks, and EMR alerts, the strategies needed to screen particularly vulnerable patients, for example, those presenting with psychiatric or high acuity presentations, those who do not speak English, and those who are undocumented, the comparative effectiveness of conducting a brief survey, for example, 1 to 2 items, and then a more detailed questioning for those with potential risks and needs identified in the general screener, versus starting with a more comprehensive screening for multiple discrete social risks and needs. And finally, the factors of the payment and policy landscape. They may incentivize or discourage EDs from implementing social risk and need screening. Lastly, Objective 3 found limited information about what interventions work in the ED and prioritized understanding how evidence-based interventions from other clinical settings can be translated, describing the most effective interventions in reducing social risks and helping address patients' social needs, identifying ways to improve patient linkage with resources and services, and defining patient-centered outcomes. Thank you.
Thank you so much. I think you've given us a phenomenal research agenda, or several research agendas in that area, covering all the way from the development of screening to thinking about how we tailor that screening to our populations who have the highest rates of need, how we make that feasible within a policy landscape, and how we measure the appropriate outcomes. We're going to give an opportunity for the second group to present now.
Thanks, Maggie. I'm Amy Zaiden, and I will be discussing our results with Basan Sali, who's here as well. And just a quick shout out to our group members who I put in the chat as well, who are amazing and really helped us throughout this process. So I just wanted to provide a little bit of background for our group. The goal of our group was to operationalize structural competency into emergency medicine education and emergency medicine research. And while we won't go into great detail about defining structural competency, we really wanted to broadly focus on how to think about how emergency physicians can respond to systemic causes of health inequities, specifically focusing on structural forces, including but not limited to social, historical, political, etc. To do this, we first started, similarly to other groups, with a scoping review of the literature. looking specifically at structural competency and structural vulnerabilities. And the scoping review was based on the terms, just the two terms, structural competency and structural vulnerability, but yielded about 155 relevant results, or 123 relevant results for research and 55 relevant results for education. We then used a data extraction variable to extract specific data from those articles, both quantitative and qualitative, the qualitative results of which helped us form the education and research frameworks. So with that, I will let Basan talk a little bit more about the education framework first.
Thank you, Amy. As Amy mentioned, this really was very much a new endeavor in terms of applying structural competency to the field of emergency medicine. And when we looked at the educational literature, what we really focused on was work that was published either in the United States or Canada. And we looked at a broad set of articles, including opinion pieces, published curricula, and research, either agendas or priorities or like research on learners. What we found was that the bulk of the 55 articles we identified was really in the form of either opinion pieces or people really sharing their experiences on kind of like a very small scale with applying these frameworks with learners. So like a single class or a single school. And what we really wanted to do based on that was to actually apply it to a much broader level such that we actually have a more unified curriculum, one that is kind of having a national sort of skeleton curriculum to sort of talk about structural competency, to say that we are using the same terms and applying the same principles, but also have it be adaptable and usable in the local framework to be respectful kind of variations in both regional and local kind of variations in these processes. In order to also have really standardized measurable outcomes, we also proposed that the core competencies by which we actually measure learners be developed. And I also just wanted to mention, this is not on the slide, but to also say that along with standardizing kind of core competencies and kind of developing this national curriculum, is that there's also a very important faculty development piece. Again, sort of recognizing that this is relatively new as a framework, and we wanted to kind of make sure that we also not just kind of focus on learners, but also sort of make sure that we are developing a robust educational faculty development component of it as well. With that, we also sort of proposed measuring the impact of such a curriculum and the standardization of core competencies, not just on learners, but also, and I think just is that we measure the effect on patient outcomes and patients' experiences in the emergency department. So thank you. I will turn this back over to you, Amy.
Thanks, Basan. So our group in the structural competency research framework focused on a few different things. And one was to really think about how we can ask structural competency focused questions throughout the research process. And the goal was not necessarily to create an entirely new field of structural competency research, but rather how structural competency can be incorporated into current research projects, regardless of the design, whether it be a retrospective chart review or an RCT, etc. So in order to do that, we use the framework of the research design process, starting with thinking through the research question, to then thinking through the study design, data collection, data analysis, dissemination, and finally, if applicable, policy change. So we tried to think about questions at each stage, each part of the research process that could be incorporated by researchers to really help think about how structural forces can impact both the study population and the outcomes of that research. So in order to do that, we use the qualitative results of our scoping review to think through really two main things. What are the structural forces that impact the study population and what are the structural vulnerabilities that are experienced by that, by the subject or by the patient population that is being targeted. And so for one example of this is when thinking about your research question, is to think about what structural forces have been experienced by your subject population, what structural vulnerabilities they have experienced, how that may then change or influence their participation in that research, and how your literature review has incorporated those forces as well. And then so on and so forth down the research, done that research process of thinking through the same questions within how you design the study and how you collect data. We also included a section at each, or topics at each process for how the subject or how the community is engaged in that process. And really the focus wasn't on necessarily redefining that, but if applicable, how was the subject or community involved in that phase of the work? The feedback that we got from the last 2 surveys and 2 sessions really focused on how to define community and subject engagement and how that would be incorporated throughout the research process, both if it's necessary, if it's working with the community, or if it's not necessarily related, for example, a retrospective chart review, but how that could be potentially applicable. And the other feedback we received is thinking through whether we want to incorporate sort of strength-based topics rather than deficiency-based topics in the framework, and also sort of explaining or differentiating how this is different from community-based participatory research. So the next steps for our group is to incorporate the feedback from the last few sessions, any feedback we receive from today, and then develop consensus among our working group about the frameworks proposed both for education and research, and then hopefully finalize our results and then start to think about implementation.
Great, thank you so much for sharing, Dr. Zaiden and Dr. Salhi. We'll now move on to the summary of breakout group 3.
Great. Thanks, Michelle. I'm Emily Cleveland-Manchanda. I'm an assistant professor at Boston Medical Center and the director for equity initiatives in our department. And I was co-leading breakout group 3 along with Hannah. And Anna, do you want to introduce yourselves before we dive in?
Yeah, hi everybody. Oh, sorry, Hannah, go ahead.
You go for it, Anna.
I'm Anna Darby. I'm an NCSP fellow at UCLA and working at a few different hospitals throughout LA.
And I'm Hannah Janeway. I'm the Ideal Fellow at UCLA here in LA as well.
Awesome. So our strategy for approaching this process was very similar to what has been shared by the other 2 groups. We, for group 3, were seeking to explore the existing literature surrounding race, racism, and anti-racism in emergency medicine. And so we also started with a scoping review. I wanted to just display these few quotes that we use to help frame our conversation, because I think the way in which we started thinking about these questions and the context in which we were conducting this work was really important to us. And so we started with some words from Adrienne Marie Brown, which I'll let you read for yourselves as I talk here. But our process was very similar. We started with a scoping review of the literature and identified initially 344 articles which related to emergency medicine, racial bias, racial discrimination, and similar keywords. The articles were reviewed by a core team of about 15 of us and were included if they addressed how race or racism affected emergency medical care in a variety of ways, including access, utilization, treatment, outcomes, patient experience, or provider experience in the emergency department. And then all of our reviewers used a structured sort of data abstraction tool and also reviewed the citations that were included in those relevant articles. And we ultimately included 187 papers, as well as an additional 34 that were found from the citations of those. We organized the papers into 10 different domains. And then from those domains, our group developed a list of 45, I believe, questions and or recommendations that related to future research focused on addressing race and racism in emergency medical care. Those questions were sort of the starting point for our community organization input. We had community groups from across the country help us to review and reframe and shape our research priorities. And I will turn it over to Hannah to talk about sort of our process for the last 2 sessions and what we identified in terms of results.
Yeah, so I don't know if we can go to the next slide, but after we identified a series of domains, and I think Emily kind of included most of them, but we split them into, a general domain that just really talked very generally about race and anti-racism and the large overarching scoping things that we need to look into and change in emergency medicine. And this is principally because there is actually very little literature on this. We managed to get 188 articles, but that was by including a lot of things that were related to just access or whether or not a patient had to utilize the emergency department instead of their primary care provider in order to have treatment for an underlying condition, as well as methods, access to insurance and primary care, ED utilization, ED operations. We did a section on health outcomes in specific diseases and conditions. So there were specific diseases and conditions that were kind of highlighted more, for instance, asthma, stroke, things that were actually pretty easily measurable, which was a common theme that had, door to TPA time, for instance. We did a section on the intersection of the legal system, community, and societal structures in the ED, focusing some on carceral systems and law enforcement in the emergency department, and that's intersection with race. We had a domain on provider perspectives and faculty development, patient perspectives, implicit bias, and the direct health effects of discrimination. I think, our big overall take-home point of all of our literature review that was done by a very large team of individuals was that there is extensive research. Most of them have been large sort of database studies, but there have been smaller institutional or site studies that document that there is racism and that, there is very inequitable care for people of color in our emergency departments. However, despite this research going back decades, showing that, there are these disparities, there have been very, very few. I mean, in the less than 5 studies group out of 188 that document that we're trying to create solutions and measuring whether or not those solutions were effective. And not even just measuring them. There's barely no articles even just on trying to create a solution and the process in trying to create the solution. And I think that's going to be probably the focus of much of what we end up putting forward in our recommendations is further funding and research efforts towards, number one, doing more interventional studies, and number two, kind of trying to rethink how we think about research and what's considered to be viable research and how it has to look. Some of the work that we did at the beginning really focused on, what is the research structure and how was it built and how has it participated in racism and violence against Black people, and that's well documented. And therefore, if we're starting with a structure that is inherently racist, how do we then use that structure to advance anti-racist work? And so I think that was a focus of a lot of our discussion. And then during the 2 sessions we had where we discussed the different findings and recommendations in the domains, we kind of whittled it down to discussions about what is actually feasible under the umbrella of emergency medicine. How do we incorporate larger structural forces that need to be dealt with in order to create equity, such as, insurance systems, capitalism? How does academic medicine fit in there? and really this need to incorporate patient perspectives and patient experience in emergency departments and how people experience emergency departments the way they're currently set up. And so through that process, like Emily said, we sent out a survey kind of trying to rank our domains and our recommendations and findings. And ultimately what we hope to come up with is a list of priorities for how to kind of move forward in this work, both in the way of how do we structure a response that isn't racist in and of itself, and how do we actually advance anti-racist work that we can all be proud of.
Yeah, thank you, Hannah and Emily. And just to kind of wrap that up and moving forward, and what Hannah's saying, echoing that as like a huge frame shift for how we're thinking about research in general. And for me, and I think for all three of us, we kept coming back to this question that we had kind of generated in the beginning, which is, what would an ED that centers the needs of our most marginalized and vulnerable community members look like if an ED were designed to care for a Black or Indigenous, queer, transgender, non-English speaking woman with a history of trauma? How would it work? And how might we transform our system into one that works equitably for all patients? And obviously those questions have not always been incorporated into research objectives in emergency medicine in the past, but the more that we can push for this to be on people's minds, even if they're, looking at door to TPA time and they think it has nothing to do with race, it all does, right? And just making sure that we're kind of moving the needle forward in terms of thinking about race and racism in emergency medicine. So thanks, guys.
Great. Thank you so much for those excellent summaries and the incredible amount of work that went into those 2 consensus sessions. So again, we have pasted the session selection for the next session. So please, if you've not done so already, change your name to, ideally you'll just change them to both right now, but at the very least select A, B, or C, and you will be assigned to one of those 3 sessions. If you happen to have the most recent version of Zoom, you may see an option to select your own breakout, but in case you don't, or if you're still in the main room, it's probably because you haven't been assigned to a session. So again, the sessions are completely unrelated to the consensus research agenda that was just presented. They're going to be projects in progress from various presenters across the country. Identity and health relates to different aspects of gender, culture, race, et cetera. Healthcare systems relates to access and systems of care and how that intersects with social emergency medicine. And session C relates to how we can better incorporate education and training, or social emergency medicine, into education and training. Thank you very much. And we will see you back in the main room in 50 minutes. So that'll be 3:20 Central Time.
Next up, we have Dr. Ishwaran from UCSF, and going to talk to us about a study that is in development.
So much, Liz. Hi, everybody. My name is Vidya Ishwaran, and I'm a fellow in the National Clinician Scholars Program at UCSF. And I'm going to be talking about a project in the early stages of conception. I'm working on IRB or propel right now, which will be a qualitative study examining the relationship between health and pretrial detention in Harris County, Texas, which is my hometown. So next slide. I want to just start with a few basic statistics, and it was after hearing about these issues that I became interested in pursuing this project. Harris County is the county which includes Houston, Texas, and currently over 70% of indigent defendants charged with felony crimes are assigned court-appointed attorneys who have more than the recommended number of cases. With too many cases, this leads to substandard legal care for these clients. Furthermore, the U.S. has the most number of pretrial detainees in the world, with the average length of pretrial incarceration being about a month. 1 in 5 of those in jail report taking a prescription medication before going to jail, and of those, almost half stop taking their medication while in jail. Additionally, and interestingly, in Harris County, you are allotted 2 free health visits for acute needs when you're in jail, after which you have to pay $10 per visit, which may not sound like a ton, but for those in jail with significantly limited income streams, this can be a significant barrier. Next slide. So I use this socioecologic model to help me think about the relationship between health and incarceration. I've personally seen many patients in the emergency department immediately after release from jail, and some of the other work I have been working on shows that we also see patients immediately prior to incarceration. Many of these patients are experiencing houselessness or have concomitant mental health or addiction concerns. This model shows that how at every level, there are opportunities to address inequities and the problem of mass incarceration and how this can impact an individual's health. And I use this model to come up with themes for my interview questions in each of these areas. Next slide. Okay, so I have 2 specific aims for this project. First, to see if an individual's health considerations impacted circumstances leading to their arrest and incarceration. And 2, if pretrial detention impacts health, and if so, how. Next slide. In this work, I'm partnering with a community-based organization called Restoring Justice. Restoring Justice provides holistic and client-centered representation to marginalized members of the community facing criminal charges. This includes the provision of expert criminal defense legal representation, social work services, trauma-informed counseling, spiritual support, volunteer connections, and more. The mission is to end mass incarceration one client and one heart at a time. They currently have about 40 clients, half of whom have been released on bond. All are facing felony charges, and most are Black men in their 20s and 30s. To qualify for their services, you must be indigent and currently represented by a court-appointed counsel and have an active pending criminal case in the county. Next slide. So for this project, I'm planning to hold 60-minute in-depth semi-structured interviews with 20 of the clients. All of them have been released from jail at this point, to ask questions about the participants' experiences with pretrial detention and health. I hope to have representation from Restoring Justice caseworkers or even their social work interns with me during the interviews, and will plan to present my findings to the Restoring Justice staff to receive feedback on my interpretation and analysis of the data as part of a community-based participatory research approach. All of these interviews will be held via Zoom. Next slide. I will then use the Braun and Clark 6 steps for thematic analysis and perform a theoretical thematic analysis, which is concerned with addressing specific research questions, and then utilize open coding with pen and paper. Next slide.
1 minute.
Great. So I will focus my questions on these 3 themes. First, how did your health and well-being impact your life pre-arrest? 2, how was your health and well-being impacted while you were in jail pre-trial? And 3, has there been any long-term impact on your health and well-being during the time you spent in jail pre-trial? Last slide. And so I was asked to talk briefly about barriers and facilitators. One of the biggest barriers was the inability to talk with individuals currently incarcerated. It's a role that the Sheriff's Department has in Houston, and funding is always the barrier. Facilitators are, I think the biggest one is a shared mission and priorities with my community-based organization that I'm working with. We both have interests in ending mass incarceration and abolition, and so it was great to be able to find a community organization to partner in this effort with me. Thanks.
Thank you so much. And just so people who are maybe joining a little bit late can see the schedule, our very lovely tight schedule is in the chat. Thanks to Shaw pasting it there. That was a wonderful presentation. Thank you so much. Next, we're going to move on to Megan Hewlett. You with us, Dr. Hewlett?
Yeah.
Okay.
Yep.
Great.
I'm here.
Fantastic.
Awesome.
Take it away.
Perfect. So I'm Megan Hewlett. I'm an emergency medicine resident at UCSF, and my presentation is on conducting a cluster analysis of high users of multiple systems in San Francisco. Next slide. We have no conflicts of interest to disclose. Next slide. So in San Francisco County, we have a database of high cost and complex patients called the Coordinated Care Management System, otherwise known as CCMS. It was implemented in 2005 with the initiative to understand the drivers of frequent users of the ED and inpatient system. And through CCMS, we came to discover that frequent users of the medical system also frequently use behavioral health and social services. And to represent that and reflect that, we now characterize these patients as high users of multiple systems, otherwise known as HUMS patients. The database has grown to over 450,000 individual patient records with up to 20 years of data for each patient. Next slide. CCMS is an integrated database in that it compiles data across multiple domains of health. This includes medical, mental health, and substance use disorder diagnoses and services use, as well as housing status, shelter use, interaction with the criminal justice system, insurance status and finances, as well as support systems. Next slide. And CCMS has applications across multiple levels. At the population level, it identifies and prioritizes HUMS patients and assists with the development of interventions and programs. At the program level, the system can flag a patient that's used the ED again or a particular service and encourages crosstalk between programs in an effort to minimize redundancies or gaps in care. And at the patient level, providers can see a comprehensive view of each patient as they are listed in CCMS and then also understand where they're touching the system. Next slide. So here I have a pictorial representation of using CCMS. On the left, I have an example HUMS patient. And at the top, I have arrows indicating their comorbidities and risk factors. And at the right are arrows indicating their service usage. On the top left, you have this patient has medical comorbidities, but given that there's no arrow to the top right indicating a hospital, this patient may not traditionally flag as a frequent user of the medical system. However, if we look at housing or shelter service, which is second from the bottom on the right, providers of this particular service prior to CCMS may be aware that this particular patient frequently uses their service, but they may be unaware that they're also frequently using substance use disorder and jail health services. CCMS, though, serves to remedy this by giving us access to not only just one domain, but multiple domains of service, and would show that this patient is touching multiple points of service. Next slide. Here we have another example patient, and while they fall within the same HUMS patient population, they have an entirely different profile. And this illustrates the heterogeneity of HUMS patients as a population and suggests that they likely have differential management needs. Next slide. Okay, so taking this further, we conducted a study where we identified the top 5% of HUMS patients by calculating a HUMS score by tallying up the total number of urgent and emergent medical, mental health, and substance use disorder services for the 2019 and 2020 fiscal year. Those with the top 5% of HUMS scores were included in our cluster analysis, where we employed a k-means cluster algorithm and identified 5 characteristically distinct subgroups that differed on the basis of comorbidities, demographics, and service usage. And you can learn more about our project tomorrow at 2:42 p.m. Next slide.
1 minute.
Thanks. So we had some barriers were being able to handle mixed categorical and continuous data, and finding an algorithm that handles both, a cluster algorithm, which we're working on. Additionally, we only had access to CCMS data, so there may be some elements of patients' utilization outside of this where we don't capture that. And additionally, CCMS is unique in that many systems outside of San Francisco County don't have access to such an integrated system. And therefore, at present, our results only apply to San Francisco County. Next slide. So our results highlight the need for multiple targeted interventions in order to effectively address the needs of our HUMS patient population. And while CCMS is unique, we hope that our results may inspire other groups to adopt integrated data systems or methods in order to increase crosstalk between service providers. CCMS has been instrumental in many systems improvement efforts, including as recently as the COVID-19 pandemic, by helping us to prioritize homeless individuals for isolation and quarantine hotels, and then also enabling us to evaluate how effective placement is in terms of service usage. Next slide. I want to give a special thanks to Benioff Homeless and Housing Initiative and San Francisco Whole Person Care. Thank you.
Thank you, all three of you, so much. Those were outstanding presentations. Just a quick note, I know that this seems rather packed and rapid paced. We erred on the side of trying to highlight a wide spectrum of work. And while there's limited time for discussion, the agenda link that Shaw put in the chat has contact information for all of the presenters if you want to ask them any types of follow-up questions or engage in ongoing discussion. We'll also pass on any questions we don't get to today to each of them. We do have time for a little bit running behind schedule, of course. So we have time for one question right now. Shaw, did you have one question? Yeah.
Yeah, thanks, Liz. I'll forward along the question Dr. Gavin asked in the chat to Dr. Davuluri. So there are actually two questions, but I'll ask the first. How has this information been received by your hospital or ED leadership? And has ongoing conversation about implications or interventions been initiated?
That's a great question. And unfortunately, I'm not Dr. Davuluri yet. I'll be there in a few years. So the project was very heavily involved or conducted by the Diversity, Equity, and Inclusion Committee that is formed by emergency department physicians out of the Henry Ford Hospital's Department of Emergency Medicine. Because of the level of involvement from emergency department leadership from the very beginning, from the creation of the project all throughout the survey development and the analysis and development of intervention ideas, it has always been very well received. And I think that that was actually a very essential factor to really getting the survey implemented and having the confidence that even if we were to do this survey and collect these sort of perspectives from patients, there would actually be something to do and implement on the back end. I think that if there was not that sort of support and confidence from the very beginning, a lot of the encouragement around doing projects like this that would incorporate patient perspectives in such a fruitful way that would impact organizational change would not have been done.
Thank you so much. We're just going to move into our next section, and then hopefully at the end we'll have time for some more questions as well. Thank you so much. Okay, so next we have Henry Ashworth. Henry, you're there? Okay.
Yes, hello.
All right.
So my name is Henry, and today I'm going to be presenting on a visualization tool called VLens, which stands for Visualization Linking Emergency Needs and Services. And this work was done at Massachusetts General Hospital and overseen by Dr. Margaret Samuels-Kalo. Next slide. So our main disclosure is that this grant was funded by AHRQ. Next slide. So the overall goal of this project was to see if we can meet 3 different needs of 3 different populations. So first, if we could create a visualization tool that would help patients identify local resources that are relevant to them, whether they were housing or food related. And then second, if this visualization tool could also help healthcare organizations such as ACOs better adapt their services to understand where there are areas of high utilization and low resource in the community to better meet the needs of the patients that they serve. And then finally, at the highest level, looking at state and local lawmakers to see how we could look at the needs of patients, their constituents, and also areas where there's low resources so they can provide better policy decisions to meet the needs of their community. Next slide. So to meet those needs, we wanted to create a tool that allowed for the visualization of the intersection of 3 important themes. And those themes are healthcare utilization, community resources, and then the social determinants of health. And each of these themes corresponds to a primary color on our final visualization map. So utilization was in yellow, resources in blue, and then social determinants of health in red. And for each one of these themes, we had a subset of data. So for utilization, it was hospital discharges. For resources, it was community health centers, and then dental providers that took public health care, as well as the 211 community resources database. And then for the social determinants of health, we had a number of national indices, including the social vulnerability index, the neighborhood stress score, and then some population demographics that are available through the American Census Survey. Next slide. So this is a quick, this is a screenshot of a prototype tool. I sadly don't have time to walk through it, but at the bottom, I've put the web address where you can access the map and play around it yourself. And kind of how the map works is the map key on the right has each of those themes. There is the subset of data that can be toggled on and off, and that you can look at the intersection of the three themes across utilization, community resources, and the social determinants of health. And then we also were able to overlay the community local transportation map so that that could be toggled on and off as well. Next slide. So for barriers and facilitators to implementing this tool, I think the biggest barrier overall was the availability of public data. We sadly weren't able to access ED utilization data or ambulance calls because those were associated with fee. And then second, there was quite a variation in how this data was broken up. Some was by census tract, another was by zip code. So we had to track back to get everything at the zip code level, which caused a little bit of skew in the data. And then for visualization, looking at these three domains, they're kind of complex, especially with all the subsets of data, to really get a clear system to looking how they all intersect together. So I think moving forward, it'd be interesting to look at a combination of color and texture. And then also on the right, the map key could probably be improved for more user accessibility. And then the final point, which moves into the next slide on future implications, is really taking a human-centered design so that this tool could be adapted in a number of different versions to really meet the needs of the population that can be designed for. Next slide. So for future implications, I think to really be a powerful tool for Bedside, this visualization map needs to be streamlined to really work for patients or a provider who's walking through a patient at the bedside, but it has a really powerful impact to really have, for a patient to be able to see kind of what resources are accessible and what resources they need on a map that's interactive and also has public transportation. I think other interesting future questions moving forward, instead of just looking at all of ED utilization, looking at specific subsets. So for example, looking at ED utilization for dental complaints, and then looking at the dental clinics in those areas where patients come from, and if they have public health, they accept public insurance, or if they're open to taking more patients. And then finally, I think the real power of this tool is to look at the intersection of these three themes. So going back to a policy and larger planning perspective, or where are the areas of high need, high utilization, and are there actual community resources in those areas to provide and to meet those needs? And if not, how can NGOs or can larger state organizations then use that information to empower them to make better decisions to provide for their constituents? Next slide. And here's my contact information, and then one last time, the web address where you can access the map.
Great, thank you so much. So I'm actually going to, this includes a nice little video. This next part. So let me just get this up for our next presenter.
Thanks for your help with that, Liz.
Oh yeah, no problem.
Sorry to be difficult.
Oh, I watched the video and I was like, I see why he wants it now. Okay, that's very helpful. I'm going to share that. Look, present. Got it. See, okay? Okay, great.
Yeah, perfect.
Go ahead.
It looks great.
Toph and Nicholas, right? Yes.
Yep.
All right, let's go.
So, hi everybody. I'm Toph Peabody, and Nick, do you want to introduce
Nick
yourself?
Stark.
And we're
Yeah,
from
Nick
UCSF.
Stark.
We're from UCSF, and we are part of the Acute Care Innovation Center, and we represent a diverse and multidisciplinary team of emergency medicine faculty, residents, medical students, nurses, social workers, designers, all passionate about improving acute care.
On the next slide, we're excited to tell you today about our social interventions product, which is a digital discharge navigation tool that helps clinicians provide patients with tailored community resources based on their specific demographics and needs. Next slide.
And our story actually starts all the way back in 2019. We recognized, like many of your departments, that our emergency department acted really like an island. We're at a large urban training hospital. We see over 72,000 patients per year, 30% of which are homeless patients. We provide really intense, expensive care in a short period of time, and oftentimes without integration into the broader community health network. In short, our patients come to this island of the emergency department, and then we discharge them basically on a raft and hope they land safely at the mainland. And so we set out to see if we could develop a training tool to help patients navigate, or give them an oar, so to speak, so that patients could make it to the mainland easier. And our hope was to avert some of the high social needs admissions to our hospital by connecting those patients with community resources directly from the emergency department. And trust me, after many iterations, we developed a digital teaching tool to help clinicians determine appropriate discharge resources for patients in coordination with our social medicine and social work teams.
Next slide. So to do this, we started with a design thinking approach to learn about our audience and clearly define the problem. This included over 80 hours of research with multiple interviews and clinical site observations. And it also involved close coordination with our existing social medicine and social work teams to determine workflow challenges and bottlenecks. This ideation phase eventually led us to a digital calculator style tool that after multiple rounds of user testing, we officially rolled out on February 9th of this year. So on the next slide, I'll show you a quick demo. First, I select which resource area I'd like to learn more about. And from there, I'm asked a few specific questions about my patient's demographics and preferences. And after answering those, there it is, a curated list of community resources specific to my patient. I can quickly browse which actions I need to take as a clinician. And then by clicking on one of the listed languages, I can access and print a single page handout for my patient that comes in one of 5 languages and shows additional details about the community site, including its contact information, resources, and services. Next slide. The back end of the social interventions tool required a lot of intentional structuring. So each module, such as the housing resources module showed here, is backed by a decision tree that's ultimately based on the expertise of clinical and community experts that help determine which resources are most appropriate for specific patients. On the next slide, in addition to our decision trees, our team also keeps an updated spreadsheet of resources by coordinating closely with community sites every quarter. We utilize this information to both keep our web platform up to date, as well as to develop and maintain single-page patient information handouts like the one shown here. Next slide.
So we encountered multiple barriers while bringing this project to life, and most notably, our scope was initially very broad. It's actually too broad. And we planned to develop 10 modules for our initial launch, and after delays with COVID and including too many community resources adjusting their hours and requirements or closing down, we realized that in order to test and launch the tool in a reasonable time frame, we would need to focus more intently on a couple of areas. So we poured all of our energy into housing and substance use resources. And by focusing on those 2 areas, we were able to develop and launch the digital tool more quickly. Next slide.
So ultimately, our tool is helping redefine community resource education for clinicians at our hospital. Our last slide here includes our contact information. And a big thank you to the SAEM Consensus Conference team for allowing us to share our project with you today.
That was great. Thank you all so much. We do have time. Henry,
yeah, there was a really quick question to be that can be answered pretty quickly, I suppose, guys. Is this integrated into your EHR?
Yeah, so we have this tool is part of a broader clinical information hub that's directly linked from our health record system. So you can link out to it. It's a separate website. It's not like within the EMR, but there's a direct link to it from the EMR.
Great, thank you. We have a number of questions coming through. And so Liz will just help me manage time here a little bit, but one question was, do you have plans to research the tool and patient and/or provider level effects? This would be to Dr. Peabody and Stark.
Well, I'm glad you asked that question because yes, we have an IRB approved study that we have sent out surveys for already. And so we are researching the effects on the knowledge of the providers and want to think creatively about how we can actually think about patient outcomes, but it's not part of our initial study.
Thank you. There have been a couple of questions around funding for the tools that you are creating. So I don't know if Dr. Stark or Peabody, if you want to go first.
Yeah, that's a great question. A lot of this has been very resident and faculty and med student driven. So we have a pretty big team, including some undergraduate students, medical students, residents that have helped build this from scratch, coordinating closely with social work and social medicine teams at our hospital, have built this for basically next to nothing. Our main cost has been translation of these patient handouts that we can print for patients, which we applied for a patient care grant for and received a small amount of funding for that. But otherwise, it's been very much just on the hard work of our team.
Thank you. A question for Dr. Ashworth around you mentioned variability as a barrier to some of this process, like the ability to be precise. So how do you implement a process that accounts for some of this variability region to region or over time? How do you think about that?
I think one of the constraints we had was that we had to use publicly available data. And I think when you look at larger data sets, a lot of times they're pretty clear whether it's census tract or a zip code. And I think as things get more standardized, it'd be easier to implement, especially if you're making a larger map that looks at all ACS data, that it's gonna be easier to do. I think as you get more local and you're looking at local community resources, it's gonna be harder to integrate those. One thing we did though, is instead of looking at just zip code or census tract, was looking at the actual address. So I think that's one way to get around it. But I think it's gonna always be an issue kind of across the board when it comes to zip code versus census tract for the data.
Thank you all so much. That was great. And thank you, Shaw, for curating those questions. We're now almost on time. So we're going to move on to the next three presentations. And then my hope at the end, the final Q&A section, if you have questions for the first three presenters who presented in the session, to please ask your questions for them as well. We'll have some additional time, hopefully, to ask about their important work also. You guys see my right screen, correct? Not presenter notes. All right. Okay, great. Just checking. So first, we're going to start with Roger Winters. Roger?
All right. Good afternoon, everybody. My name is Roger. I'm a third-year medical student at Brown, and today I'm going to be talking about the implementation of an ED community healthcare peer recovery program for patients with substance use disorder. It's called SMART. It's a really exciting program being led by Dr. Samuels, and it's made possible by the long list of people seen here. Next slide, please. So Rhode Island has the 10th highest accidental overdose mortality in the United States. Additionally, folks who visit the ED for a non-fatal overdose have a really high risk of death within a year. And the ED is often their only interaction with the healthcare system. So since 2014, the emergency departments in Rhode Island have offered patients treated after an overdose consultation with an on-call peer recovery specialist. A 2016 Rhode Island law requires the provision of peer recovery counseling. But as you can see, the efficacy of that has not been great. About 70% of patients were offered ED behavioral counseling or take-home naloxone. And unfortunately, only 30 and 40% respectively were actually receiving those interventions. Next slide, please. We saw a similar lag with referral to treatment, where there is a huge gap in folks being able to be linked to treatment. It peaked at 40% when the law went into effect, but has since declined to only 15% being connected to treatment. So it's because of these gaps that SMART was started. Additionally, before SMART, the ED didn't have a way to address social needs that were often at the core kind of driving force of substance use disorder. Next slide, please. So what is SMART? In addition to being an acronym, it stands for Substance Misuse Assistance Response Team. It was started to improve the uptake of ED behavioral services and linkage to treatment. It's a multidisciplinary team that centers around the community health worker, peer recovery specialists, who I'll refer to as CHWs, as well as a clinical supervisor and medical director. The SMART CHWs are in the ED in the morning all the way to the late evening. They engage clients at the time of their ED visit, provide individualized support and counseling, linkage to treatment, harm reduction services, assistance with accessing social services, and longitudinal case management for those who need it. So the CHWs follow patients outside the ED until they're able to be linked to a more permanent programs in the outpatient setting. SMART was started around the same time as ED Care, which is a similar intervention that also employs community health workers for folks who are frequent ED utilizers. But today I'm talking about SMART. Next slide, please. So before I go into the results, I want to highlight some of the barriers and facilitators. Barriers to implementation have included a lack of ED staff understanding of the CHW's role. There has sometimes manifested as CHWs being questioned or interrupted during client encounters, having their legitimacy as part of the medical team questioned. COVID has also been a pretty significant barrier, both in terms of logistics of a shared working space and as well as the person-centered nature that is the job of a community health worker. It's been challenging to balance having a community health worker in the ED at all times with the CHW's commitment to their longitudinal clients outside of the ED. And so one thing we've done recently is we now have a new CHW, Mike, who's in the ED exclusively, and that's working out really well. I really want to highlight that the ED leadership and HR have been great facilitators, both providing a departmental grant and a lot of enthusiasm for the program. Next slide. Great. So let's take a look at the results so far. So far, SMART has provided services to, next slide, 121 people, 64% of who are followed on longitudinal caseloads. 34 clients were referred to mental health treatment, of whom 70% have received that treatment. A quarter of our clients have been referred to harm reduction services. Almost half those have been able to access the services. And then 45% have received health-related support, including food access, insurance assistance, transportation, and housing. And regards to housing, advance one more time, is 27% of clients have been provided housing services, and almost 2/3 of those have actually been housed either temporarily or permanently. Next slide, please.
1 minute.
So in conclusion, SMART is a new approach to substance use disorder management in the sense that it has an emphasis on CHW's unique ability to connect with clients at a critical juncture and be able to help them access services outside of their initial ED encounter. We've learned that the ED CHWs are a feasible program, and the preliminary results are really exciting. We have encountered significant organizational and COVID-related barriers to implementation, and are beginning the next steps of analysis, which will take the form of qualitative interviews assessing both feasibility and acceptability. Next slide. And so here is my contact information. I'd be happy to answer any questions. Thanks a lot.
Thank you, Roger. Good job. Next, we have Dr. Hardy from UCSF.
Hi, everyone. I'm James Hardy from UCSF, and I'm here to talk about homelessness, substance use disorders, and community partnerships. Next slide. So we all know the problem. Patients with substance use disorders who are experiencing homelessness often receive fractured care. And for providers on the front line like us, it can feel like we are giving Band-Aid care and throwing our patients in a revolving door. Next slide. So to tackle this problem, we adopted an idea from UC San Diego and created a community partnership program. What we did was team up with 2 local residential rehab facilities that provide wraparound psychosocial services. And the idea was to place discharged patients directly from the hospital into these programs and to skip the middle step of going back to the street. We paid our first partner $95 a day for up to 30 days to help offset the cost of care. And although this was not free, it turns out to be a good deal. You can see that for 1 month at $95 a day, that equals about the direct costs of just 1 hospital day in our facility. The other partner was not able to accept payments because they're a community safety net program that takes Medi-Cal, but we helped them with a bottleneck at intake, and the partnership eventually led to the development of a mobile intake team where this facility would actually come into our hospital, do the intake there, and then drive away with the patients in a van directly to the facility at the end. Next slide. Here's a look at our referral numbers. As you would expect, they gradually increased as the word got out, up to about 21 a month. Next slide. And then let's go over the return on investment numbers. We looked at 1 year pre and post referral, and some of the patients only had 6 months of post referral data, so their usage was imputed to 12 months for the sake of comparison. And with those caveats in mind, we estimated that with the community partnership intervention, inpatient admissions decreased by over half, as did length of stay and ICU days, as well as direct costs for patient care. And the contribution margin fell too, but that does make sense because we didn't make as much money on these because this was a cost avoidance program. But in our overcrowded hospital with high demand for services, that was acceptable. And then looking at insurance coverage, you will see that most of our patients were covered by Medi-Cal. Next slide. So putting that all together, the estimated impact for 250 referrals for that year resulted in a direct cost savings of $1.9 million. You can see the avoided ED and inpatient days there. Next slide. So one thing I'd like to emphasize is how hard it is to calculate ROI. There's really some complex measurements and considerations to make. The lowest hanging fruit for us, beginning as providers talking to our C-suites, I think is really to talk about length of stay and readmission rates, and but also to never lose sight of the fact that value is important. If you want to talk about value with a capital V, you have to talk about patient and provider satisfaction. And to communicate value, I think it's also good to talk about patient stories. So next slide. Here's a case I like to use to illustrate the value of the program. You can see this is a patient that was seen frequently in the ED and often admitted to the cardiology service. He received the intervention to our community partner here and returned only once when he had an NSTEMI, which was fair enough. And then he was able to go back to the facility and has not been using substances and has a primary care doctor and a cardiologist since that time and has been much healthier. Next slide.
1 minute.
Wanted to go over just some how-to tips. If you're interested in doing something like this, I would recommend getting to know the community services around you and find out what's in it for them, what are their pain points, and address those. Well, similarly, understand what your own hospital is afraid of and where their pain points are. Don't forget, for doing all this, you're going to need a memorandum of understanding, and so you'll have to get legal and your contracts people involved. Choose some metrics that to follow and report on, and to meet often with your community partners. And then while you're doing that, remember to be patient when you're asking for change with them because it is a partnership. Okay, next slide. And with that, these are, we face many barriers, but I have to say we had great support from the hospital and it's been a really great experience for everyone. I'll leave it there and open up for questions.
We have one more session before questions. Sorry, last but not least.
Great, sorry.
Thank you. That was great. That was great, Dr. Hardy. Really appreciate it. That was a great program. Clapping. Everyone's clapping. Silent clap of Zoom. Alex, are you with us?
Yep, I'm right here.
Okay, great. And then after following Alex, we'll open it up to remaining Q&A before the break, before the next section. So go ahead, Alex.
All right, great. Good afternoon, everyone. My name is Alex Reardon. I'm a third-year medical student at the University of Michigan. I'll be presenting on VOTE-R's student-driven Healthy Democracy campaign. I want to highlight that this presentation draws on work in progress by our research team, led by Talia Ruxin, with help from Dr. Madeline Grade, who's on this call. So next slide. First, some background. So 2016, these are 2016 figures. 56% represents the voting age participation in the United States. That is all eligible voters participate around 56. Registered voters, which is a different figure, participate in elections by voting in 2016 at about 85% clip. So to address kind of these long-standing gaps between overall registration or overall electoral participation and registered voter participation, which is kind of a unique United States problem, the National Voter Registration Act of 1993 was passed to meet voters where they are. And so when they access social services, either through the government or in healthcare settings, as we are leveraging that norm for this project, voters can be asked about their registration status and registered by those programs. This is the same law that authorizes the DMV to do that job. And why is this relevant to healthcare? I don't need to tell you folks, we're well aware that the socio-political determinants of health can influence up to 80% of our patients' health. And those are in many cases downstream of policy, politics, and governance, which can be influenced by the vote. And substantial evidence, robust research indicates links between civic engagement and self-rated health, as well as improved mental health, and that work is ongoing. So if we can go to the next slide. So we've asked, what can we do about it to kind of expand how to meet these patients where they are, as I mentioned. And the emergency department has been seen as a place to meet vulnerable patients and patients who are also likely to be unregistered voters and get them hooked in. So to build kind of a culture of civic engagement going forward, the Healthy Democracy team wanted to target their recruitment for this at medical students. They reached out specifically to students involved in organizations with a social justice bent and get them involved and have them recruit their own networks to get people plugged in. Those identified student leaders were then given the tools, which I've kind of added to the slide here, kind of these physical badges, which serve as both a facilitator and a tool in the sense that they are kind of provide a prompt in the clinical setting to remember to ask patients, for patients to ask their providers why they're wearing those, and for colleagues to ask each other where they got those. So we think that this is part of the method, but also part of the facilitator that kind of led to the success of the program. And importantly, participants were never working in a vacuum. Leadership thought it was important to leverage the kind of competitive medical student stereotype to their advantage by designing an online leadership leaderboard and competition that tracked voters engaged by each school. So we asked ourselves, what happened as a result of this approach, which I think we could also categorize as facilitators. If we go to the next slide, we'll see that teams at 80 medical schools in 31 states and DC prepared 15,692 people to vote. That's requesting mail-in ballots, checking registration status, and getting registered for the first time. So that was thought to be a great success and beyond what was expected out of this medical student program, due in large part maybe to those facilitators that I mentioned on the last slide. And how could we have done better? There were some barriers to overcome, which are on the next slide. So these kind of words here signify, varying reasons that leadership or individual providers or students may have actively or passively resisted participating in the project. So optics, time, and logistics maybe all sound similar, but the idea is that projects like these get lost in bureaucracy without real champions. It's kind of a logistics problem and a time problem. They can be shot down due to concerns over appearing partisan, which is explicitly an optics problem, lack of funding, logistics, or COVID-19, of course, kind of swamping the department and taking up a lot of the oxygen, as it were, for projects like this, as someone else mentioned earlier. Or they may be turned away due to pre-existing duplicative work. All of these and other barriers were identified either in post-campaign surveys or just within kind of brainstorming among Healthy Democracy campaign leadership. So going forward, if we go to the next slide.
30 seconds.
The idea is to evaluate kind of the turnout data and what outcomes these patients had after they were registered to vote in a healthcare setting. We can hear more about that on Thursday from Dr. Madeline Grade at this conference. And talks are underway to forge new relationships, institutionalize old ones, and do this again this year, despite not having the banner election year that we had last year. We can go to the next slide and wrap up since there's just a few seconds. And I'd be happy to take any questions either here or you can reach out to me via email.
That was great. Yay for Alex, yay for all of our presenters. So we are going to move into a Q&A, and we're going to go until, Maggie said we can go until 3:35. So before we go to the Q&A, though, I just want you all to know that the Social EM and Population Health Interest Group meeting is on Thursday, and we can talk about more of these amazing things then. So you should try to come to that. Shaw, do you have any questions for our most recent speakers or any of the other speakers you'd like to share with the group?
Yeah, let me try to filter a couple over. And if I missed your chat, basically, if you feel like your question wasn't answered in the chat because there's been a lot of conversation there as well, please feel free to jump in.
And I'm saving the chat. So if you have any questions, just put them in chat. We will save the entire chat and we'll go through them. So don't be afraid that your question is not going to get addressed. Just be sure to put down who the question is for so that we can get it to the right person.
Absolutely. Thanks, Mo. So from Dr. Alter, I'll just start with that one. To Alex, Dr. Reardon, so do you have any information or any way to get information about whether folks registered through VoteER actually voted?
Yes, so we believe so, and Dr. Gray, feel free to jump in, but my understanding is that with the information we've collected, which is relatively minimal, but we should be able to cross-check that with data made available later. Usually that will come out in the summer of this year, but we will see. That is definitely of interest to see whether previous research has shown that voters who are engaged by nonprofits tend to turn out actually at higher rates than people who are engaged either on their own or by DMV or something like that. So we're interested and hopeful that, if your doctor asks you to vote or asks us if you're registered to vote and helps you do that, that might be impactful.
Yeah, and I'll just chime in. Alex is totally right. We're actually working on this now. We just got access to some voter files, so stay tuned.
Excellent. This is an earlier question from Dr. Jacobson for Dr. Winters around the peer recovery specialist program. Just more generally, wanted to hear more about organizational barriers to implementation. I think you touched on this already, but any other thoughts there?
Yeah, race has been one of those parts of the organizational barriers, with most of our CHWs being people of color, and questioning of a person of color's role in the treatment team when they don't quite not familiar with that person, and just things like not being allowed into the ER at a certain time, or folks not thinking that somebody was part of the treatment team, figuring out where they're going to sit in the ER, in the pods, a lot of those kinds of things.
And any other questions from the group while I just try to look through the rest of the chat here?
So Dr. Khatri has a question.
Khatri, yeah. Thank you.
Yeah, I'm sorry.
Go for it, Liz.
Okay, so Dr. Khatri says, aside from the departmental chair, who are the key health system departmental leaders who were critical to your successes, and how early did you engage them? That's an excellent question. Does anyone want to tackle that? Dr. Hardy, I don't know if you want to talk about with your program at all.
Sure.
Dr.
We were
Hewitt,
lucky.
I don't know if you want to talk about with your program. No, go ahead, sorry.
I'd go straight for the kill and get the CMO. Get your CMO involved if you can, and why not? So we also have a value czar, and it was helpful to work through the value improvement program. But through that program, we were even able to get, present kind of regularly even to the CEO. So these kinds of programs, when the C-suite is hearing about them regularly, it really helps. So try to get the word out, and you will find that you'll get support more than you thought.
Got some other.
I can piggyback off of that answer actually and talk about VOTIR a little bit. We found that because we worked with a lot of institutions across the country, like more than 300, and we found that places like UPenn, for example, where from the C-suite there was a ton of support, so we call that like grass tops, and then there was also all this grassroots support that they happened to register, I think, like 20 times as much as anyone else. So super important if you can get that buy-in.
Melissa's giving us our 1-minute warning. Any other final words? I just want to thank all of our presenters. You were outstanding. Our lightning rounds of health services work. This is absolutely excellent. I feel inspired and energized, and I will see you all in the rest of the session and hopefully on Thursday also. So thank you, everyone. We'll that link has contact information for presenters. If you want to contact folks with questions, presenters, we will be sending you questions and people's information who asked them in the chat. So you'll be able to receive those as well and respond to them directly. Thank you all so much. Really appreciate it.
When it's coming back, I'm just going to remind you to please pick your room for the second round of breakout sessions by changing your Zoom name to D or E. If you're not sure which group to pick, we put the agendas for both groups into the chat, and you'll want to change your name, not put your group choice in the chat. Thank you so much.
That allows these types of interventions to be replicated across the country. So just a little bit of housekeeping. We have a terrific group of presentations from around the country, from Hawaii all the way to Boston. I posted a link in the chat to the agenda. And on that Google Doc with the agenda today, I've just listed my email. So contact me if you want to contact any of the presenters. We are pleased to have projects in several different stages, from advanced types of initiatives to initiatives that have been developed and are still in progress. And we have 3 groups. The first is 4 presentations focusing on screening and navigation for material needs. The second is 2 presentations on housing, particularly housing during COVID-19, and a final presentation on food insecurity. Each presentation will take 5 minutes, and we'll do 1 to 2 questions after each presentation. If you could put your question and discussion in the chat, that way we'll be able to ask those questions and we can stay efficient rather than speaking up. I'd love to have a more open conversation, but can't do that now. So with that, I'm going to share the first presentation. Sorry. Okay, great. So the first up is Rhea Shields from United Healthcare. Go ahead, Rhea.
Thanks, Austin. Can you hear me? Awesome. So as Austin mentioned, my name is Rhea Shields. I work with United Healthcare. So I work on the Hawaii Accountable Health Communities Project. It's a 5-year federal grant with the Center for Medicare and Medicaid Innovation within CMS. And we are currently in year 5 of the grant. Next slide. The initiative works to bridge the critical gap between clinical care and social services in the healthcare delivery system by testing whether systematically screening patients at the point of medical care for social needs and connecting them to community resources impacts healthcare costs and utilization. And so on the map here, you can see we partner with 4 different healthcare organizations across the island of Oahu, including 3 emergency departments, which are highlighted by the stars on the map. The model components consists of screening all Medicare and Medicaid patients at our partner clinical sites. And the screening includes questions regarding a patient's social needs around living situation, food security, utilities, transportation, and safety. And then based on how the patient responds to the screening, community resources are provided for the identified needs. And so for those who fall into a high-risk category, which are individuals who report at least 1 social need and at least 2 ED visits in the past 12 months, they're offered navigation services. And so at all stages within the project, we collect data to help us better understand the social need prevalence and gaps in community services. And then also throughout the entire project, we conduct continuous quality improvement. And we've also developed some key learnings with respect to social needs screening and referral, cross-sector partnerships, and data-driven interventions, which I will highlight in a minute or two. Next slide. So here are a couple examples of the type of data that we collect and review. So the data here focuses on screenings completed by patients seen in the ED. So here you can see the highest reported needs are food and living situation. This is pretty common across all different clinical type settings. So we also screen in outpatient clinics, labor and delivery, and behavioral health. Another note, 47% of screenings reported 2 or more needs. And then on the bottom of the visual, you can see that of those who qualify for navigation and who opt into navigation, we track the outcomes of their needs. And so 44% have documented positive outcomes. So either the patient's needs were resolved or the patient was connected to resources to meet their need. And only 2% resulted in the need not being met by resources available in the community. And so this is the data that we really want to focus on to better understand gaps in services. And we further break down the data by looking at the specific referrals related to those needs that were unavailable. Next slide. So throughout the project, we found the following opportunities to help us improve our work. First is integrating into current workflows. So we really found it essential to get buy-in from ED staff and leadership, and ensuring that all staff are aware of this screening and the potential impact it could have on their work. And so to do this, we observed the current workflows, and I also identified the best times to integrate the screening into current workflows. We tested a couple different type of processes and found that the best time to offer the screening in the ED was after the patient received some level of care. We did a couple tests in the beginning. We tried offering the screening right when the patient checked into the ED before they saw the provider, and that did not work out. Patients wanted to get their primary concern addressed first. So after some testing, we really understood that it was better for the patient to receive some level of care before being offered a social needs screening. We also conduct staff training and refresher trainings on a periodic basis and utilize multiple quality improvement methods and tools throughout implementation to test out and improve processes to ensure staff have the resources they need to assist with their work.
We have just 1 minute left.
Sure. I'll just highlight 2 more things here. So some other opportunities transitioning from screening to navigation. We have 2 different models, either 2 different staff members, one serving as a screener and another serving as navigator, and ensuring a warm handoff, or having the same person doing both. And then the last one here is focusing on needs and gaps in services, and utilizing data to understand gaps in services. Next slide. So this slide focuses on our lessons learned, and I've bucketed it into 4 different categories: screening, navigation, evaluation, and partnerships. And so for screening, one of the key things that we've learned, and it's a requirement of the CMS grant, is to use a standardized assessment tool. And this really helps us analyze the data and understand need prevalence based on clinical setting, demographics, and region. And it also really helped us with our QI strategies to really understand how our tests were changing data. For navigation, we worked closely with our community service providers to understand services, capacity, and referral processes. And we also worked with staff to understand and ensure there was no duplication of services. So we clearly outlined the roles and responsibilities of staff members. And then for evaluation, we collected data at each phase throughout the project to really understand patient needs, impact of the project, and gaps in services. And we also would share aggregate data with key stakeholders. And then lastly, around partnerships, it was really essential for us to engage cross-sector stakeholders early in the process to help grow support for the work and align efforts with our organizational goals. And so we convene stakeholders from the healthcare and social service sectors regularly to review progress and data, discuss key aspects of the project, and collect input on how to best implement the work and address gaps. And that's it.
Great.
Thanks, everyone.
Austin, do we have time for a couple questions, or should we go on to the next presentation?
I think we have time for one question.
Okay, so it's sort of the one question I see is, did United Healthcare compensate facilities for recruitment, and did they pay the CBOs or, pay for these community-based services?
So the federal grant funds paid for the staff on site for the screeners and navigators. And so those staff were paid for, but we did not have funds to pay for the community-based organizations and their services. So those we were just partnering with them and referring out the patients to the CBOs. They did not receive additional funds.
Great. Thanks so much, Ria. It's really exciting to hear about. All right, our next presentation is from Henny Hong from Boston Medical Center. Are you on the line?
Yes. Can you hear me?
Great. Yes. Go ahead.
Everyone. My name is Henny Hong, a second-year EM resident at Boston Medical Center. I'm honored to be here today. Next. Since 2017, BMC has implemented a program called Thrive, focusing on screening and addressing the social determinants of health of our patient populations. Over the past 4 years, this program actually expanded to 13 different ambulatory care clinics. And as of September of 2020, we started implementing a partial screening in our very own adult ED. So what does it look like? Patient gets registered, and anybody who's eligible for screening that day, our triage nursing staff screens the patient, and the result directly gets logged into our electronic health records, which is EPIC in our case. And that prompts two different actions. One is addition of ICD-10 code that responds to the screening result. And second is an automatic attachment of a referral guide to the discharge paper. Next. In the ambulatory care clinic setting, we actually screen for 8 different domains, but after many feedback and discussions with our triage nursing staff, we currently have shrunken down our screening to 5 different domains. So we focus on housing, food, transportation, utility, and unemployment. Next. It was important for us to make sure that this result is easily available to our providers so that our MDs and PAs can incorporate this result in medical management. So we decided to insert this result in the middle of the disposition tab on EPIC, as you can see. Next. For any patients who screen for at least one, screens positive for at least one social needs, a referral guide that we have built in collaboration with our ED social work team gets attached to the discharge paperwork. And if anybody screens positive for food emergency for that night, a prescription for our very own BMC's food pantry will be attached to the discharge paperwork as well. And we're actually talking about this more on Friday as part of the food insecurity panel. So anybody who's interested, please join us. Next. So far, based on the pilot screening, we have learned that about 14% of our patients have endorsed housing needs and 19% food needs, and 13% of our patients have endorsed employment needs as well. Next. This project would not have been possible without long-standing history of rigorous social advocacy within our hospital and in our department. But I have to say, trying to implement this social screening in a very busy urban ED has not been easy and comes with many different barriers. Next. Because of that, we're only able to screen a partial portion of our patients that meets ACO criteria only, and that's really Medicaid and uninsured patients. And that actually shrinks down to 10% of our patient volume. Next. And we also found out that amongst the 10%, only 50% of those eligible patients are actually receiving the screening through this flow by our triage nursing staff. And that's largely because of, understandably, work burden and limited time resource. Next. From doing follow-up phone calls to our patients, we learned that not enough discussion is actually happening between ED staff and patients about the referral guides. So a lot of times patients are not aware of the resources that are being provided to them. Next. And lastly, we are also aware that this one sheet of referral guide that we're giving out to our patients is not one size fits all. Next. So what are we doing to address these barriers? Multiple things. First, we have recently completed a QI project in our urgent care to have a better understanding of the prevalence of our patients' social determinants of health. And hopefully with this information, we can secure more resources and we can step closer towards a universal screening. We also are working—
1 minute left, sorry.
Thank you. And we're also working really hard on improving the nursing engagement through focus groups and sharing more actionable and relatable information, such as patient success stories and upstream impact of understanding the social needs. And maybe we need to move away from human resource altogether and lean more towards digital screening. We're encouraging our providers to have more active discussions with our providers, with our patients about the resources. And lastly, we're working very hard on tightening our partnership with our ED social work team, as well as external community organizations, to make sure we can provide more practical and customized resources to our patients. Next, and next. Thank you. Thank you. I'm very excited to share this project with you. I'm looking forward to hearing from feedbacks and comments.
So one question for you, I think you sort of addressed it. What was the standard expectation about discussing the social service referrals that were added to the discharge summary, and sort of who did any discussion? And if someone was expected to do that discussion, did you do any training for them?
So currently in the ED, we have not done sort of formal training. That's certainly one of the action items that we have to address the barriers. The person who is supposed to have this discussion is whoever is discharging the patient. And in our ED, it could be a mid-level provider, so a lot of residents, or nursing staff. So that's certainly one of the areas that we're working really hard on to raise awareness and have our providers feel more comfortable with the type of resources that we're providing to our patients.
Great, thank you.
Thanks.
We have time for one more question, Dennis.
Does anybody have an additional question? If not, I have one. I'm sort of curious, how long does the screening take? Because you said, you initially started longer, you narrowed down to a smaller number of fields, and sort of, did you get a lot of pushback from the staff for doing the screening? So I guess 2 questions.
Yes, so ideally the screening takes less than 5 minutes. And I think most people can do it within actually 3 minutes. It's actually pretty simple set of questions. The problem is, this is not the only screening that our nursing staff is asking. As you know, there is a whole set of questions that the nursing staff has to ask. So even just 3, 4, 5 more questions, even if it's just 2 sentences, it's just a huge work burden on their part, understandably. And because of that, we have been working really closely with the nursing staff and the leadership to work this out. Pushback, yes, it was initially a big thing that we had to work closely with in the ED leadership. And that's partly why I think it's one of the last departments that we were able to roll this screening out after having rolled this out in 13 different ambulatory clinics. But we're really excited that we're now we got our foot in the step of the door to start with a partial screening, and hopefully we can move towards the universal screening down the road.
Great. Thank you so much. So next we have Evangeline Murray from Denver Health. Again, talking about screening. Go ahead.
Yeah. Thanks so much for having me. Really awesome to be here and hear about all these other projects. Like I said, I'm Vanjie. I'm one of the third year residents at Denver Health. I'm going to talk to you today about our screening and navigation program at Denver Health and how that we kind of had to adapt during COVID-19 because we started kind of before that. And so Rhea Shields actually just gave a great description of the AHC screening and navigation model, and hers seems to be a little bit farther along than our program. So it's awesome to see the inspiration in their reach. So that was really cool. So so glad that I'm here and able to see a lot of that. And I can kind of quickly go through this since I don't think we really need to beat a dead horse in terms of describing this. People are pretty familiar. But basically, we also have a screening and navigation program that started in October 2019 that uses the accountable health communities model. Denver Health partnered with the Denver Regional Council of Governments, also called Dr. COG, which is just a local organization that helps us with our funding. Oh, can you go to the next slide? Sorry. And funding and provide staffing for the screening and navigation for us. And we thought this was a great opportunity for that just because they have a lot of experience doing screening and navigation through this area agency on aging that they have. And so there was, a lot of initial work from scratch that we didn't have to do because they already had the experience in how to hire and train people to do this sort of work. The limit obviously is that like these other ones, we were only able to essentially screen and help Medicare and Medicaid patients, which is a large portion of our population, but not the whole amount. Next slide. All right, so, and let me go to my next slide, sorry. So the Dr. Cog navigators, they work in RED. We try to get them to go to high volume shifts in the ED and then screen as many patients as they possibly can. And that was kind of the initial goal, let's just see how far they can get. Similar to what she had described before, high-risk individuals were people that had greater than 2 ED visits and any health-related social need based off the screening questionnaire. They qualified for community resource referral and navigation. And then anybody that was medium risk didn't necessarily have those visits, but had pretty much any health-related social need based off the questionnaire, and they received resource handouts. And so things were going pretty well. And then COVID hit. Can you go to the next slide? And so we had to switch to working remotely and calling into patient rooms. So pre-pandemic, we were mostly doing in-person screening, and we looked at a 3-month period from November 1st to January 31st, right before COVID hit. And then we kind of compared that in this analysis to a 3-month period during the initial peak of COVID from March 1st to May 31st. And so we were pretty worried having to switch from going in person into these rooms to having the screeners work remotely, they wouldn't be able to have the same reach that they were able to have beforehand. And so we wanted to specifically quantify successful screenings both before and after, and just look at the straight numbers, and then also just describe if there were any differences in the HRSNs that reported. Next slide. And so for our results so far, the total enrolled in this analysis was 1,258 patients, 666 in the 3 months before the COVID peak, and then 592 in the 3 months afterward that we looked at. And so, taking 3 months before, 3 months after, it's pretty amazing that they were able to screen almost the same amount of people, despite having a lot of limitations on going to rooms and, the times of day that they were able to work and things like that. Of the total patients that were screened, over 60%, 60.4% had at least one health-related social need. Of those, 158 qualified for the resource handouts, and 44% qualified for community resource referral and navigation. Next slide. Okay, and this is a little bit more about the specific health-related needs that were identified. So the most common need was food, about 31% total. And then that was followed by transportation needs. We did notice some trends before and after the pandemic. None of these were statistically significant, but kind of made sense given that we were given the issues that were going on. So, increase in food insecurity, increase in housing instability and need for utility assistance, increase in issues with interpersonal safety, and then a decrease in transportation needs because people weren't going as many places as they were before. Next slide. Okay, so in summary, we were pretty excited about the fact that we were still able to kind of have at least some degree of screening and navigation despite having to work remotely. We feel that we were able to demonstrate some adaptability and that we were able to continue the pilot and switching their modalities. We also feel like we were able to demonstrate some fidelity and that we maintained that original goal and that original like movement with the navigators to screen, refer, and assist as many patients as they could. They were super on board with getting in for phone screening and trying to keep up the momentum with everything. And so an ideal long-term goal would be to go to the point that we are able to screen everybody, because obviously one of the limitations here is that we haven't been able to 1,258 patients over 6 months. That's not nearly the amount of patients that are coming into RED. It's hundreds of thousands. Can you go to the next slide? Which leads me to talking about some of the barriers and limitations we face as we try to expand. So one of these is just simply not having enough funding for Navigate hours to reach all the eligible patients, having to train more navigators, which can't just be done by anyone, and then being limited only to Medicare and Medicaid patients at this point, and the fact that for our analysis, this was a convenience sample to analyze for efficacy, and really just patients that presented during the when the screeners were there. And so some questions I have, and I'm hoping for some advice on this, is how can we best assess for efficacy moving forward? Like, what data should we look at when we try to look and see, are we actually like having an effect here? Is it just % of potential patients screened? Is it successful navigation cases? Is it a decrease in repeat ED visits, patient satisfaction, decreased overall costs? A lot of these aren't necessarily even patient-centered, and should we be asking them, and how can we appropriately ask them? And we want to recognize that handing someone housing resources isn't necessarily the same as actually handing them and helping them get housing. And so we know that this isn't perfect, but we hope that by at least screening and providing some form of support and also documenting the need, these data can be used to demonstrate to administrative and legislative bodies the high needs in our community, even if we're not able to necessarily meet them for each patient. And so hopefully we can use that to advocate for better social services for our patients.
Great, thank you so much.
Great. A few questions in the chat all refer to sort of comments on around the interpersonal violence and how the rate jumped from 0 to 19%. And there was a lot of curiosity. Did the methodology change? Were the questions being asked change? Or why do you think that jumped so much? I know we do realize people were at home more and at higher risk, but it seems like a pretty remarkable jump.
Yeah. And again, like the sample size. So that was actually one of the questions, so there were 3 questions in the questionnaire that reflected that, and they weren't always necessarily answered by every single patient. And that might have had a difference, in the fact that when you're asking those questions in person, people may have not necessarily been as forthcoming, whereas like having a little bit of that barrier, and this is me just providing some conjecture, maybe potentially people were more likely to answer honestly. That being said, there was not a significant, it looks like a clear jump, but it was a little hard to make an assessment, I think, with the sample size we have. So I think, with COVID and everything, and the risk for interpersonal violence is something to consider. And I think one of my mentors, Dr. Roosevelt, had some commentary in there as well, but that's what I would say to that.
Right.
I also want to note that there's some great questions in the chat. We'll be distributing those to the speakers and sharing with the group. I think I just want to highlight Dr. James' question about screening for root causes of these needs, and Dr. Duran's comment about the earlier consensus conference. I think we'll be developing a great report. I think asking questions about the questions in some way, and I think it's an unsettled question about the methodologies that we're using for screening. Great.
Okay. And I think just while we're jumping, just to provide a couple thoughts on sort of what is interesting, I think it goes back to, from my perspective, what do people care about, right? Like, I don't think, given the pandemic, we've seen that ASAP and ED docs don't necessarily enjoy a decrease in ED volume for different reasons, probably not the right reasons per se. But I think in terms of the payers, I think decreasing ED visits, right-sizing care, and making sure that ambulatory care sensitive conditions are are seen in different locations other than acute care are probably all ways that could, if you show screening and navigation, lead to connections for those resources and leads to decreased utilization. I think you've had plenty of payers who would be very much on board in resourcing the screening beyond the convenience sample.
Great. Thanks so much. All right, our fourth and final presentation specifically about screening and navigation. Ava Lerner, are you here?
Yes, hi. Hi, everyone. So my name is Eva Lerner. I'm a program manager in the Division of Community and Population Health. It's a pleasure to be here. I'm accompanied by Dr. Betty Chang, who's the medical director for the Adult Emergency Department at NYP Columbia. And we'll be discussing something very familiar to all of you by this point, our efforts implementing the Accountable Health Communities model at the Columbia Emergency Department. Next slide, please. So I'm not going to go into great detail because you've heard it already, but the Accountable Health Communities Initiative aims to test the feasibility of screening for social determinants of health and addressing the social determinants of health through alignment between medical and community-based services, ultimately to try to achieve the triple aim of improving population health outcomes, decreasing avoidable utilization, and decreasing cost. And the idea is to bring together the clinical community with the social service community in collective action. Next slide, please. So just brief description of our community. We're located in Inwood, Washington Heights. We also receive patients from all over the Bronx. And our patients' median income is around $57,000 with a poverty rate of 14.5%. So it is a fairly high need community, large immigrant population, mostly Spanish speaking. Next slide, please. So to try to diversify the presentations a bit, I'm going to focus a bit more on our IT integration in our work with patient navigators, but essentially the model that we really tried to push forward was starting with integration of our IT systems, and then of course using that to screen for patients or screen patients for social determinants of health, stratify patients according to their risk level, navigate patients to community service providers, and ultimately try to achieve health and social service alignment. Next slide, please. So first and foremost, we integrated our EMR with our social determinants of health platform, which we selected to work with NowPow. And so screening takes place in 3 locations. There's a patient-facing screening that can happen remotely via Epic's patient portal, MyChart. We also have in-person screening via iPads using their e-check-in platform, Welcome. And then, of course, you can screen directly into the EMR using flow sheets and assessments. We then built NowPow directly into Epic so that it can be launched through Epic, so that information from the patient chart flows directly into NowPow, and there is a bidirectional flow there. And then all of the referral and downstream navigation occurs directly in NowPow, which is really where the bulk of the intervention occurs. Next slide, please. So when we first started this model back in, we started really implementing it in September of 2018, we relied heavily on a volunteer model using in-person tablet-based screening, and we had to develop essentially parallel operations. It was very challenging to sort of integrate screening and referrals into our emergency room clinical operations, and I would be very curious to hear from some of my colleagues presenting here how you've been able to align your operations more. So we started with a volunteer-driven model. We eventually hired full-time screening staff to support this work. And then in February 2020, we had to pause screening as we rolled out a new EMR. So I mentioned that we built Epic or NowPow into Epic. We'd previously been working with Allscripts. And so as you can imagine, rolling out a new EMR is a huge lift, and we had to sort of pause screening operations. Once we were up and running again, the pandemic hit, and we had to continue to pause our operations because of completing priorities in the Columbia emergency room being sort of the epicenter of the pandemic. In September, we were finally ready to reintroduce screening operations again, and we started a process of recruiting student volunteers as well as using our existing screening staff and moving to a telephonic screening model post-discharge. But again, this continues sort of the parallel operations, and we wanted to have more sustainability and more integrated work. And so in November 2020, we began a partnership with our patient navigators who existed already in the emergency room to navigate our patients who are uninsured or underinsured to primary care and specialty care. And now they have taken over operations or taken over responsibility for screening. Screening continues to happen post-discharge telephonically, but there is more operational alignment. And eventually, when operations return to the hospital setting, we will be able to have in-person screening again. Next slide, please.
Sorry, 1 minute left.
Okay, so very quickly to describe our patient navigators. They existed in the ED and in inpatient long before we rolled out the Accountable Health Communities model. They've been with us since 2009 and have still steadily increased their presence. And their purpose to deliver a bilingual, peer-based education and support model and really work as members of the ED and inpatient teams. And this was our top priority, to make SDoH screening and navigation sustained beyond the duration of the model, of the Accountable Health Communities model. And so partnering with a pre-existing program that has operational support was really critical to ensuring its sustainability. Next slide, please. So this is just a quick run chart of sort of our screening numbers. As you can see, when we were purely volunteer driven, we did not have a very large reach. When we added full-time staff, our numbers increased significantly, but really there is a much more steady incline when we started to partner with the patient navigators. Next slide, please. We can skip this slide since we discussed community service navigation already, just some brief results. Our percent of need was a bit higher than some of the other presenters. About 34% of our patients have a housing need, 39% are food insecure, and nearly 60% have at least one need. Of those who've received navigation, we've been able to resolve about 56, 60% of those needs, but a large chunk remain unresolved because of the high proportion of housing needs and the housing crisis that New York City is facing. Next slide, please. So just very quickly, some barriers. So originally, IT integration challenges, staffing and resource constraints. When it was purely a volunteer model, we really were not able to reach the number of patients that we would like, and it was poorly integrated with clinical operations. And so once we were able to partner with the Center for Community Health Navigation and work with the Patient Navigator program, we've increased our reach. We've ensured longevity and sustainability. And now it's really about continuing to perform ongoing training and capacity building with the patient navigators to get them more comfortable talking about these issues, since their bread and butter is really on navigating to primary and specialty care. So I'll stop there and allow time for questions.
There's just one question while we get set up.
Go for it. I don't see any questions in the chat for you specifically. I guess the one question from me from the IT integration standpoint, in terms of the two-way flow, how did you guys get the community-based organizations to use NowPow to give you feedback? Did you have to pay them, or sort of how was that incentivized?
Yeah, so when we first went live with the program, we put out an RFP and recruited some initial early adopters to work with us on the closed loop navigation. We did incentivize them with some funding. We're not technically allowed to pay for services through the Accountable Health Communities model, but we paid them for their participation in our advisory board. Now, as we start to expand our reach and build that network further, there are some community organizations that really have indicated that they will need some kind of incentivizing to receive referrals through the platform. But others, and actually other smaller organizations, are just excited to be able to partner with us in this new sort of streamlined approach. And I think the ability to get more patients in there, get more patients referred to them and be able to use it for data and for numbers was really an incentive alone. So I'd say some of the bigger, more established organizations do want that funding incentive, but some of the smaller ones who are just happy to get more referrals are excited to pilot a new model like NowPal.
Great. So are we going to stop for sort of a question for all the panelists from this first group, or are we going to wait for later?
I think we're running a little tight, but I think if let's fire one off, maybe if you have a good one for the whole group.
Yeah, I see one from Hazar in the chat that says, can each of the speakers talk about some of the specific facilitators that helped you set up your programs for those who are just at the drawing board and wanting to establish similar programs?
I'm sorry, was the question for me? Could you repeat that? I apologize.
I think it's for all four of the presenters. Just talking about how you were able to go about setting up your programs and any tips you might have for people who want to emulate the work that the four teams presenting here have done.
I can speak a little bit from the Denver perspective. So we were actually really lucky that Dr. Cog knew about accountable health communities and had a lot of motivation to want to set up a navigation program, and had actually reached out to one of our attendings, Dr. Roosevelt, about this, and then they worked together to develop it. And so it's likely that there is some local agency that is responsible for that funding or finding a way to incorporate accountable health communities where you are. And if you can figure out who those players are, they might be able to help get some of this going, because they were immensely helpful in running the actual nuts and bolts of it.
I think we should probably keep moving. I think that's a great question for the entire group, and definitely to reflect on. And I think for everyone here, thinking about what are some common facilitators that each of these presenters noted and barriers. I think that would be really constructive. But we should move on. So next presentations will be specifically about housing, and actually specifically about housing during COVID-19. Haruna, are you here?
Yes, great. Well, thank you so much. My name is Haruna Iradomi, and I'm currently a second-year medical student at the UCSF UC Berkeley Joint Medical Program. Today, I'll be talking about the impacts of COVID-19 in California Senate Bill 1152 on discharge processes for patients experiencing homelessness. Next slide. Right. As we all know, homelessness is a significant issue, especially in California, which has the highest count of people experiencing homelessness of any state. And California has been at the forefront of addressing social needs in healthcare settings as well, and is the first state to pass a law to address the social needs of people experiencing homelessness within hospitals. So this law, California Senate Bill 1152, is an unfunded mandate that went into effect in January 2019, which requires hospitals in California to standardize the discharge process for patients experiencing homelessness that come into the emergency department or are hospitalized. So the detailed requirements of the law are presented here, and some things I want to highlight are that first, patients must be screened for homelessness, and if they are experiencing homelessness, must be provided resources like meals, care coordination, and transportation to a shelter within a 30-mile or 30-minute radius. And all of this must be documented. Next slide. This is such a unique law. So what we wanted to see is, first, did SB 1152 influence discharge processes in hospitals in California? And what are some of the barriers and facilitators to implementing the law? And finally, how has COVID-19 impacted this, if at all? Next slide. So to answer this, we designed a qualitative study and conducted semi-structured interviews with 2 to 3 key informants who were responsible for implementing SB 1152 across a maximum of 16 hospitals in either Humboldt County, which has the highest rate of people experiencing homelessness, and Los Angeles County, which has the highest number of people experiencing homelessness. Eligible hospitals were categorized by ownership status, so dividing between public, nonprofit, or for-profit, and then randomly selected to participate. So far, we've conducted 23 interviews across 14 hospitals, and analysis was done using the consolidated framework for implementation research. Next slide. So far, one key takeaway is that we actually see a lot of commonalities in implementation, facilitators, and barriers between public, nonprofit, and for-profit hospitals. We also found that actually most of the services required by SB 1152 had already been in place across many of the hospitals, but the law changed the discharge process by making it more organized overall. And one participant describes how SB 1152 increased accountability, saying, with SB 1152, I think less things fall through the cracks because there is a system of checks and balances. There were, however, also challenges to implementing SB 152, which all revolved around the lack of resources, whether that was community resources, funding, or internal staffing. And one clinical social worker highlights this in a quote: "It's almost like having family come over for Thanksgiving, but all you have is top ramen and a half of jug of water in your fridge." And finally, COVID-19 is not making any of this better or easier. So in fact, informants have talked about how there's even fewer resources because of the pandemic. And with shelters shut down and testing that initially had a long turnaround time, overall, it's becoming even more difficult to properly discharge homeless patients to safe living spaces, particularly from emergency departments. One CNO stated, when all of the resources are refusing to take patients until you COVID test them, and then some facilities have their own independent rules, it has really impacted flow. So again, all of this, sorry, go back one slide. All of these are still preliminary findings, and we're continuing to interview hospitals, but even at this stage, we can really already see some implications, particularly for state legislatures. So these findings emphasize that the effectiveness of future state level health policies will hinge on first investments in the community, like long-term housing supports, social services, and mental health supports, which is especially important in the context of the pandemic as well. And second, adequate funding for hospitals to implement the required changes in their workflow. Next. So some challenges to this project thus far include, first and foremost, COVID-19, which resulted in paused recruitment during surges in the summer and winter, also led to interviews being conducted over Zoom. So we worked around this by including context questions in the interview guide to get a sense of what the hospital environment was like. The other biggest challenge was that we had difficulty reaching the right individuals to interview, but we were able to work with the California Hospital Association and our advisors in LA County, notably Dr. Rochelle Cooper and Dr. Brina Terra, to obtain contact points and data. And next slide. I would like to end by thanking my mentors, Dr. Laura Gottlieb, Dr. Arswald, Dr. Brewster, and Yuri Cartier, as well as our recruitment collaborators, UCSF, and the Joint Medical Program. Thank you.
Great presentation. I think we have time for one question while we get set up.
So if no one has a question, I guess, did you find that a lot of hospitals basically were just ignoring the law, given that there seems to be no enforcement, even though there initially was some fear about enforcement?
So what we found so far is that people have actually had things in place, and even with the pause in the law because of COVID, people have continued to keep doing the practices because it has already technically been implemented, and to go back to the way things were would be more work. However, there is a little bit of selection bias because with the recruitment, we kind of reached out to the California Hospital Association and hospitals, and the people who were interested in this work responded. So people who might not necessarily have been implementing this may not want to be responding to participate in our study. So that is definitely a limitation.
Fair enough. Thank you for that clarification.
Great. Two more presentations to go. The next is from Caitlin Reyes from Yale.
All right. Hi, everyone. I'm Caitlin Reyes. I'm a PGY4 and soon to be a research fellow at Yale. I'm presenting the development of a clinical pathway from the ED to hotel rooms for COVID positive patients experiencing homelessness. Next slide. The objective of this pathway is to improve care and safety of dispositions, facilitate community respite placements, reduce ED volume and crowding during a pandemic, and most importantly, reduce community transmission. Next. These are just some background statistics on ED patients experiencing homelessness, the take-home point is just that this is a vulnerable population with high morbidity and mortality who frequent the ED, making the ED an important location for intervention. Next slide. And testing and quarantining presented unique barriers in this population, from drive-throughs requiring cars, limits to hours, technology for communicating results, and quarantining without housing or shelter. Next. New Haven had a really speedy response. Shelters were diverted to hotels really early on, and a local high school was converted into a respite center for COVID positive clients, but there were challenges. The respite center was underutilized with only 12 clients in the 4 months of operation and only 1 referral from the ED. And this was due to a lack of testing in the ED because we were conserving tests for admitted patients and everyone else was referred to outpatient testing and told to quarantine at home. Next. So in the second wave, cold weather brought more indoor congregation and community spread, and shelters remained diverted. However, congregate warming centers and drop-in centers remained open and were possible sites of transmission. And additionally, symptomatic patients could not access many of these resources without a documented negative test. Next. So this time the city used designated hotels for quarantine and respite. Unlike staffing the high school, this resource was flexible and accommodated fluctuating volume, and street medicine teams followed patients while quarantining. Next. So where does the ED fit in here? Well, clearly testing is critical in facilitating these referrals to appropriate community resources. Next. So we set out to design a clinical pathway, and this emerged from like a pre-established CBPR group, of which a small cohort peeled off to form a task force. And we started with the referral process, like what were the eligibility criteria, who was the point person, how long did the process take? And this development was iterative, going back and forth between our administration and our community partners with revisions and compromises. Next slide. Our community partners included representatives from municipal, NGO, healthcare sectors. Next. And this is a diagram of the final pathway. So patients experiencing homelessness present to the ED. No COVID symptoms, no pathway, business as usual. Those who are positive and requiring admission get admitted, and the inpatient social work team handles the dispositioning. So for those dischargeable positive clients and those with a negative test but high index of suspicion for COVID, social work contacts our community partners, and this results in a cab directly to their hotel room for quarantining from the ED. Next slide. Our community partners were really keen to develop this, but they lacked an inside advocate and institutional knowledge about ED flow. And the ED wanted the path to include those with negative tests, resulting in additional costs for our community partners. Both sides were concerned about hours of operation. The ED wanted 24-hour access, and our partners work normal work hours with limits on when funds can be released. So we settled on 8 a.m. to 10 p.m., but 7 days a week. The ED also worried about testing supplies and didn't want to become a screening hub, so the community partners scaled up on-site testing at all the hotels. And the ED was most concerned about length of stay because boarding had become ubiquitous and our staff was strained treating both the ED patients and the inpatients. Next. So we approached the administration with data. The pathway in full would be utilized actually by a very small number of patients. We estimated about 100 patients experiencing homelessness would get discharged with COVID-like symptoms in a whole year. So the high estimate with a case positivity rate at 6% meant like 6 patients would enter a process that only takes 4 to 6 hours. And if you'll note, the average length of stay in this population was already 4 to 6 hours. And importantly, the other 94 would benefit from having their negative test at discharge, which served as a ticket to accessing critical resources like the warming centers. Next.
Just 30 seconds left, sorry.
Okay, so this is just the initial reception. It was really well received. I want to highlight the first quote. It came from the administrator who was pushing back the hardest. And it just shows that institutions are ultimately made of people and they want to do the right thing. Next. So these are just our metrics for evaluation and outcomes. We'll have to use a qualitative approach more likely because we didn't expect a very high number. And to that end, we'll conduct semi-structured interviews. And then next, I just want to make sure I acknowledged all the partners who worked so hard. So I wanted to get to this slide. And then here's my contact information if anyone wants to collaborate on future health and housing projects.
Terrific. All right. I think we'll maybe one question while we go to the next presentation, but we'll have to wrap it up soon so we can join for the keynote. But great work. Give me 1 second.
So, with COVID sort of wrapping up a little bit, thankfully, are there plans for sort of continuing or sustaining this work, and sort of what does that look like?
Yeah, so I'm really interested in expanding this beyond COVID, especially as a lot of like our partners in town want to continue to do hotel-based housing initiatives, and like are looking at, like Columbus House is one of our shelters who's looking at buying a hotel. And so I would like to see this continue beyond that, especially now that we have this infrastructure. So we're doing like a difference in differences analysis of places that did hoteling and those that didn't, to kind of give some data to bolster this, but that's going to take a little while.
Great. Let's jump into the last presentation. Adrian Oracocha and Noah Berlin are going to be presenting.
Good afternoon, everybody. Hi, I'm Noah Berlin. I'm here with my co-residents, Adrian Orioche and Dr. Sim. We are going to be talking about a program we developed to help try and feed patients coming into the ED with food insecurity at Kings County Emergency Department in Brooklyn. We have no disclosures. And then just as a brief outline, we're going to go over the background, the purpose and aims, plan, and what we did and what we need to do. So this is just to kind of set up a little bit of the background for even before COVID, even though COVID is kind of what really pushed us to doing this. The arrow sign points to our little part of Brooklyn, but all of that red surrounding that brown spot is all of our catchment area as well. And so as you can see, it represents millions of meals in the meal gap, even before COVID existed. Next slide. And COVID-19, as I'm sure we all know, especially because of everything that everybody's talked about before, really was a huge stressor. And it's certainly in our part of Brooklyn, we were one of the ground zero epicenters last April and March. And it really had a huge impact in our community, which had a large number of people who, in general, as presented before, have a large meal gap and food insecurity, but are also, many of them are undocumented. They don't have real access to a lot of like food security programs. There were concerns from things that the Trump administration had done. And there were also just a large number of people with jobs that were not, were in the service industry in some capacity, whether bartenders, restaurant employees, cleaners, all of who lost their jobs pretty early on. Next slide, please. And then this is to kind of show those numbers, how in New York City, this is from the New York Food Bank,
Before I introduce our keynote, I want to give a huge thank you to all the Projects in Progress organizers and speakers. The 2 sessions that I attended were both fabulous. Please make sure you're on mute. Somebody out there is not. Thank you. And we will have links so that you can go to the sessions you missed if you want to see what those sessions look like. And we will send those links out in a few days with some more information. And additionally, the Social Emergency Medicine Interest Group is actually hoping to hold more of these sessions in the future, because I know that personally they were interesting to me to see what other people were doing. And I know that the speakers themselves asked a lot of great questions of their audiences, and I heard a lot of great collaborations and the beginning of great collaborations, which is what we had really hoped would happen. So I'm optimistic that we can do more of that in the future, and I would really look forward to seeing all of you again. So we have been so fortunate during this consensus conference to have wonderful and inspirational speakers, and today is no exception. So it's my pleasure to introduce our keynote speaker, Dr. Janae Khaldoun. And I dare you all to try to remember everything I'm about to tell you about Dr. Khaldoun, because it's pretty impressive. All right, ready? So Dr. Khaldoun is the Chief Medical Executive for the state of Michigan and the Chief Deputy Director for the Health in the Michigan Department of Health and Human Services. In these roles, she provides overall medical guidance for the state of Michigan as a cabinet member for the governor and oversees public health and aging programs, Medicaid, and behavioral health for the Michigan Department of Health and Human Services. In 2021, she was also named by President Biden to the COVID-19 Health Equity Task Force. Prior to her role at the Michigan Department of Health and Human Services, she was the Director and Health Officer for the Detroit Health Department, where she oversaw a robust community health assessment, established a comprehensive reproductive health network, and spearheaded new human service efforts, and led Detroit's response to the largest hepatitis A outbreak in modern US history. Dr. Khaldun has held previous positions as the Baltimore City Health Department's Chief Medical Officer, the Director of the Center for Injury Prevention and Control at George Washington University, founder and director of the Fellowship in Health Policy at the University of Maryland Department of Emergency Medicine, and fellow in the Obama administration's Office of Health Reform in the US Department of Health and Human Services. She currently serves as the National Advisory Board for the Institute of Healthcare Policy and Innovation at the University of Michigan, the Board of Directors of Big Brothers Big Sisters of Metropolitan Detroit, and on the Health and Medicine Committee of the National Academy of Science, Engineering, and Medicine. She is an adjunct professor in the Department of Health Policy and Management at the University of Michigan School of Public Health. Dr. Khaldun has received numerous awards, including 40 Under 40 Leaders in Minority Health Award by the National Minority Quality Forum, the de Beaumont Foundation 40 Under 40 Leaders in Public Health Award, and the George Washington University Monumental Alumni Award. In 2020, she was named a Notable Women in Health and Newsmaker of the Year by Crain's Detroit. Dr. Khaldun obtained her undergraduate degree from the University of Michigan, her medical degree from the University of Pennsylvania, her MPH in health policy from George Washington University, and completed residency in emergency medicine at SUNY Downstate Medical Center / Kings County Hospital in Brooklyn, where she was elected chief resident her final year. In addition to all this, she practices emergency medicine part-time at Henry Ford Hospital in Detroit. So thank you so much for joining us. We're really looking forward to hearing from you.
All right. Can you all see my screen? Hello, hello. There we go. All right. It's always a technical challenge, but thank you for having me. I see I'm all giddy with excitement because I see some of my old friends literally going back to residency here. So it's always just really exciting to be back amongst my friends, my home, which are my fellow emergency medicine physicians. So I do spend the bulk of my time doing public health and policy in Michigan's capital. But what I'm really excited to talk to you about today is where I love being, which is the intersection between policy, public health, and medicine. So I was told I had to give a disclosure statement, and so I will. I have no disclosures. I'm not getting paid for this. And it's really important. I've learned over the past year, I hope there's no media on right now, but my statements do not reflect the official views or opinions of the state of Michigan government. So this is all Jonate Khaldun that you are going to be getting this evening. So I thought it was really important as I started kind of thinking about what I wanted to talk about today and how I frame my remarks was to talk about the city of Detroit. So I'm a practicing ER doctor. I grew up in Ann Arbor, Michigan, but then after college, I went to the East Coast and I was away. But then I had an opportunity and I was asked to come back home by the mayor of Detroit. And I can tell you, it has been really the greatest honor of my life to come back home to help a city that I love, a city that helped make me who I am, and to be able to lead the state now through the greatest health crisis in over a century. It's just truly been an honor. But I want to talk a little bit about the city of Detroit, because I think as we talk about public health policy and emergency medicine, the story of Detroit really makes a lot of sense to describe. So, the story of Detroit is really the story of my family. So in the 1950s, you can see there, Detroit was one of the largest cities in the country, had over 1.8 million people. A lot of folks, including people in my family, came up from the South to work in the auto industry. It was escaping the South, for my family at least, to have a better life for their families. And so, again, hustling, bustling, you had this great, magnificent city. A lot of people living in these single family houses with backyards. People lived actually very close to the car plants that they worked in. And then what you had, you can see that very steep decline, was a decline of the auto industry, loss of jobs. You had what many of you may know as white flight. So a lot of white people, for various reasons, which I'll get into, ended up leaving the city during that period of time. And you ended up having a lot of concentrated poverty. So you may be very familiar with this because I know I'm with my social emergency medicine friends. So this is a picture of a redlining map for the city of Detroit. So you can see one of these such maps in a lot of other urban areas, cities across the country. And so essentially, the Federal Housing Administration in the 1930s basically subsidized people to move out of the city of Detroit. So banks actually gave loans, particularly not to people of color, intentionally not to people of color, to move out of the city of Detroit. They redlined literally areas of the city where they said, not only were we not going to give you a personal home loan, but we're not going to give you loans to build up a business. And so what you ended up having were a lot of incentives to move outside of the city of Detroit. And you ended up having this very, very concentrated poverty in the city. And what you see here, those red lines are actually where you still have the highest concentrations of poverty in the city of Detroit. So I think it's also important, and I remember, again, I grew up in Ann Arbor, my grandparents, parents all in the city of Detroit. And I remember visiting some towns on the East Coast when I was looking at colleges and looking at medical schools. And I was, hadn't really traveled much outside of Michigan when I was younger. And so I remember going to, I think it was Philadelphia, New York, visiting those places and saying, well, where are all the neighborhoods? Because for me, inner city meant the city of Detroit, which is what you're looking at now, which is even in areas that had concentrated poverty, still a lot of single family homes, a lot of wide space, not a lot of high rises. Really, you can see a few there in the downtown area, but most people, even living in poverty, actually lived in these single family kind of homes. So Detroit is 142 square miles. And again, the city was really built around this kind of expectation that there would be highways. Everybody, against the motor city, everybody's gonna have a car. So you don't need any transportation system. There are no subways, no way of really getting around the city of Detroit except for a bus line. And don't tell the mayor this, but the buses aren't really that great in the city of Detroit. So it can be really hard to get around. So when you talk about the city of Detroit, remember I showed you 1950, 1.8 million people. That's really what the city was built upon. But Detroit really has under 700,000 people. And so when you talk about the city of Detroit and its geographic area, you can actually fit all of San Francisco, Boston, and Manhattan into the city of Detroit and still have space left over. So you're talking about a place that's not particularly dense. So why am I talking about this? Why is this important? What does this have to do with emergency medicine? So I'm getting to that because you are all my social determinants of health friends. When you talk about anything that you want to do in the city of Detroit, particularly, you're talking about, I already said it, concentrated poverty. You're talking about people who often don't have a car or don't have access to a car. You're talking about people who have to use public transportation for a lot of the things that they want to do, whether that's going to work, going to school, going to doctor's appointment, grocery shopping. So particularly when I was the Detroit Health Commissioner, everything I did from a public health standpoint, I really had to think about people who were in the neighborhoods and who perhaps didn't have access to a lot of the services that were necessary to, again, be healthy. And again, I think the folks I'm talking to now know about the social determinants of health. So what happens? What happens to the health of a population where you've got, for decades, strategic intentional disinvestment, the redlining, concentrated poverty? What you get is a pandemic of the century hits. And as you all know, I know more recently, but also in the very beginning of this pandemic, Detroit was really one of the hot spots in the entire country. And I think the reason for that, as you all know, has nothing to do with the fact that Detroit is over 80% African-American, has nothing to do with skin color. It has everything to do with social determinants of health, concentrated poverty, lack of access to resources. So this is Michigan's COVID-19 curve. I know you've all seen the curves look different in every state. But what you saw was, in the very beginning, we didn't have enough testing, as you all know. Our cases in the city of Michigan, in the state of Michigan, were very concentrated around metropolitan Detroit. And so we had a lack of access to testing there. Our hospitals were overwhelmed. We stood up, like some other places across the country, we stood up these kind of warehouses, unfortunately, thinking that we might have to treat patients actually in these alternate care facilities. And we really just saw these terrible disparities play out. And so Michigan was one of the first states actually to announce what the disparity was when it came to COVID-19 cases and deaths. And quite frankly, it's because I asked, I essentially demanded it of my epidemiology team. And now they're great. We were looking at cases and deaths and I said, no, I want to see it broken down by race and ethnicity. And sure enough, we saw a disparity. African Americans make up about 14% of Michigan's population, but in the very beginning, 32% of cases and 40% of deaths, which is really just unacceptable, quite frankly. And so what did we do? We sprang into action. And I think really just have so much gratitude to the governor of the state of Michigan. She went into action. We actually announced a racial disparities task force. But for me, task forces are great, but for me, it's about action and what are you actually going to do? So what do we do with this task force? Well, first of all, just for the governor to stand up and say that racism is a public health crisis and to put resources and money behind it, I think is really, really important, and it sent an important message. We actually targeted, it was about 2/3 of our entire media effort and budget for communications for COVID-19 actually was targeted in Southeast Michigan. We worked with trusted community members who was on this task force, more than 50 trusted community members who were from the community, academia, worked in hospitals, worked with schools, people who were, faith-based community, work with them to make sure we were getting out messages that resonated with the community. Distributed over 6 million free masks, a lot of free neighborhood testing sites. And again, you will all recall a year ago, you could not really get a test. And there were real disparities in who could even get a test. So we literally looked at the zip codes and census tracts where we were thinking we saw the highest number of cases, and we literally put free testing sites in those places. We funded community-based organizations. We expanded SNAP benefits, a lot of kind of human service supports that we put out. And we also, I'm quite proud, we also mandated racial and ethnicity reporting for our providers and implicit bias training for state employees, as well as now in the state of Michigan, every licensed, every licensed healthcare professional now has to undergo implicit bias training as a condition for renewing their license. So what did all that do? So you can see on the left there, and this is going back now, that March 1st is 2020, and that yellow curve is the African-American case rate. You can see very early on, really, really high disparity, high case rate in African-Americans. You can see we put so much intense effort into, again, very targeted strategies. We actually brought that curve down significantly. And you can see even through the end of 2020, we did not have a disproportionate number of cases in the African-American community. Again, a lot of work to do still, but I think we were very intentional and strategic, and it helped us really address those disparities, which is really, really important. Now, of course, this is our vaccination rates in the state. So this is particularly coverage. So of all of that particular race or ethnicity, what % of them have either gotten their first dose of a vaccine or completed their vaccination series if it's a 2-dose series? As you can see here, we still have a bit of a ways to go when it comes to our disparities in vaccination coverage, which I'll talk about in a little bit later. But I thought right now, and the reason why I'm talking about this is I think that this quote really resonates with me. Of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And that is from Dr. Martin Luther King Jr. And I think what we've seen with COVID-19, what all of you see, and why I think we're even having this conference is to really talk about those social determinants of health, how they do disproportionately impact Black and Brown people, and how if you act with intention, you can actually address these disparities and inequities and the inhumanity of it all. And I think there's a lot that you can do in the emergency department. So again, most of my life for the past year has been all about COVID. So what went wrong with COVID-19? So I'll give you a little bit of my kind of my assessment of what went wrong. So in the very beginning, and one of the things I will always remember about this pandemic, and when I knew it was going to potentially get out of control, is when my epidemiologist, she said to me early on, I think it might have been February, said, you know what? The CDC said that we are only going to be able to do testing in people who are severely ill, people who have recently traveled, and particularly, I think it was people who were hospitalized. Now, it's just common sense to know that it's a respiratory illness. Everyone's not going to be super sick. So just setting it up that way in the beginning, we knew there was a lack of testing, and we knew we were going to have a spread that was going undetected. So I think that's really where we kind of missed the ball as a country. Social determinants, meaning that a higher risk of exposure for some people. So let's think about this. You probably all know this, right? But the very things that protected you and prevented you from getting COVID-19 are the exact things that you were less likely to be able to do if you were someone of color. So what do I mean by that? We know that African Americans are more likely to be homeless. 40% of the of the homeless population, 40% of the homeless population is actually African American. We know there's more concentrated poverty in Black and Brown communities. So if you're telling people stay home so that you don't get the virus, where a lot of people don't have paid leave, they can't work from home. You were deemed essential in the very beginning of the pandemic. Our CDC guidance told people to stay in their own home, use a separate part of your house, use a separate bathroom if you get sick so that you don't expose other people in your household. Well, we're all physicians. I know a lot of us probably got our own apartments or whatever we needed to do, hotel rooms. Well, quite frankly, a lot of people don't have that privilege. And so we really set up the structures to expose more people who lack that privilege. I think also our early vaccination efforts inherently exacerbated disparities. And so what do I mean by that? Well, for one, and I tried to be very intentional about not doing this in Michigan, early on, it was healthcare workers. And of course, I understand I was one of the first ones in the state to get vaccinated as well. I worked in the front lines of the ER. But for a lot of hospitals, they decided that the attending doctors were going to be the ones that got the vaccine, not the janitorial staff, not the people who were pushing folks to CAT scan and wherever else. Those folks, frontline healthcare workers, probably spend more time with patients than some of the attending physicians, but they were not actually prioritized for vaccinations in the very beginning, which I think was a big deal and exacerbated our disparities. I'd also say that the way that from the media perspective, we were really pushed, and I'm sure you all heard it, who's first? They ranked all the states. Every day I had media at my door wondering why Michigan wasn't top, or why were we in the middle, and why were we at the bottom? Well, I'll tell you, from the very beginning, we decided that we were going to really focus on getting vaccines into neighborhoods. We still have our racial disparities task force. We were partnering. I literally took vaccines off the top of our allocation and partnered with mandated partnerships with community-based organizations, faith-based organizations, put 100 here, 1,000 here to these organizations to be able to vaccinate those who are perhaps less privileged. And so what does that do? That slows you down a little bit. But that is not what was actually prioritized and incentivized in the very beginning of our vaccination efforts. And quite frankly, that I think really exacerbated disparities. I want to talk a little bit about monoclonal antibodies. Michigan, and I hate to toot my own horn here, but I've been told by the White House that we are a shining star here in Michigan with monoclonal antibodies. You may have heard about them for people who are higher risk for severe COVID-19 illness. If they test positive and you get to them quickly enough, they can actually could prevent progression of their disease and prevent them from needing to stay in the hospital. And so what we saw early on is that a lot of the clinicians who were working in our Detroit inner city, some of our lower income areas, for whatever reason, they were not providing or offering monoclonal antibodies in that area. And so again, exacerbating disparities. And then finally, I'll talk about the lack of a robust data infrastructure. It's funny because I get the sense from this pandemic that everyone thought you could just push 2 buttons and you would automatically know where all the cases were, how old they were, if they were associated with an outbreak. Why does it take so long? You know, again, this is like PTSD from media for the past year. Why does it take so long? Why is your data not robust? And so, you know, for some of this, I actually had to put together Excel sheets, survey monkeys in the beginning of the pandemic, and probably still, there are some health departments that don't have an epidemiologist. We all know what epidemiologists are now. Some didn't have epidemiologists. Some are using fax machines. Again, the Detroit Health Department, when I left a couple of years ago, there was a fax machine. That's how we started our contact tracing. And you would make sure someone went and checked the fax machine on the weekend if you thought an outbreak might be, you know, brewing somewhere. And so that's what we started with. And unfortunately, it promoted our disparities. We're still unable to get disaggregated data. So you loop all the Black people together and loop all the Asians together into one big group. That really doesn't give you a good understanding of what's going on in communities. That makes everyone be the same. And so we know that that's not true. And so really the lack of this data infrastructure, I think, really impeded progress for our pandemic response. And I think underlying all of this is really, you know, I talked about redlining. I could go on and on. I'll try not to make this brief, but it's systemic and it's structural racism. And it literally has cost people's lives during this pandemic. So what's the point of all this? How can emergency medicine physicians strategically fight COVID-19 and I would argue other health crises? So for me, you know, everyone doesn't have to save the world. I think people often look at me and say, oh, I can't do that. I can't work at the state level. I work in the ER. You don't have to. You really don't have to. There are some very targeted strategic things that you can do as an emergency medicine physician to be able to move the needle. And so there's things you can do with the bedside. There are programs, projects you can put together in your emergency department. You can work with your hospital leadership to make it more hospital-wide. You could get involved with the community. Again, I know I'm preaching to the choir here because this is what you're all about. It's why you're here. And then I think very importantly, policy and advocacy. That is just so incredibly important. And you have so much that you can move forward as an emergency medicine physician. So briefly, what are the things you can do? So from a bedside standpoint, again, especially early on, I hope we don't get to a point where we don't have access to testing as we were a year ago, but assuring equitable access to testing. I think in the very beginning, there was a lot of subjectivity that went into who got a test. There were a lot of folks who, again, there were terrible stories coming out of the Detroit area, people who were sent home saying, well, we can't test you, but they were sent home to crowded housing where they couldn't isolate. They didn't have a car to be able to get back to the hospital if they needed to. And people, quite frankly, were going home, not knowing if they had COVID or not having those structures in place to protect themselves or others. And people were, quite frankly, just crashing and dying at home. And so making sure that you're mindful at the bedside of, even if a patient is likely to have COVID-19, maybe you can't test them, but be mindful of what their circumstances are at home. And maybe even, I think early on, people should have had perhaps a lower threshold for admitting people for observation. Supporting effective quarantine and isolation. Just ask the question, just, hey, instead of just discharging someone, hey, what's your home situation like? Do you need some support? And if you can't provide it in the emergency department, that's fine. You can work with your local health department. A lot of state and local health departments have programs to support people and with their quarantine and isolation, even had hotel rooms for some individuals. From an emergency department perspective, and again, I think there's some experts in the room already who know about this, but close referrals to housing and other things that can really help people be well, prevent them from coming back to the emergency department. One of my favorite things to talk about are our flu and COVID vaccination programs. Thank goodness, I think because people were wearing their masks so well. We haven't had a flu season over the past year, but absolutely, people are right there in front of you. We know as emergency medicine physicians, this is sometimes the only place that anyone's actually getting healthcare services. So it's an important moment. It's a teachable moment. It's an opportunity right there when they're in front of you to give them a vaccine. And so we're working in the state to be able to give COVID vaccinations in the emergency department as well. I'm sure there's others across the country who are already doing this. And of course, with the Johnson & Johnson vaccine, easy to operationally to store, and it's one and done. So really an important part, a tool in our toolbox. Monoclonal antibody infusions. Again, for everyone in your emergency department should know how to get their patients access to monoclonal antibodies. It's pretty easy. You don't need, it's an infusion. You just kind of throw it up and it goes in over an hour. I've heard some stories of people thinking you need one-to-one nursing care. I know the ERs where I usually work, no one's leaving anytime soon. There's a lot of waits and people are there for hours. So the opportunity to really give them monoclonal antibodies is really, really important. There's also an opportunity to get involved in your community. Screening, testing, vaccination partnerships. Again, I'm sure many of you are already doing these things in your community, but it's really, really important. As an ER doc, you know how to hold a needle. You tend to operationally be very strong. You don't need a lot of support. You get in there, you roll your sleeves up, and you get things done. That's just who we are. And so really offering yourself out to the community is really, really important. Supporting PPE procurement efforts, again, really early. I know a lot of my friends and colleagues help with this, but also consulting with local health departments and local businesses as well. I think everyone kind of understood the importance of public health and what a public health department is now. It's not just where you send someone to get vaccines, but it's really, really important. So that's something you can do as an emergency medicine physician. And then my favorite is really the policy and advocacy. You have to get involved. You have to advocate for the patients that you serve. You can get involved in committees at the state and local level. And dare I say it, I'm totally not interested in this, but for some of you, you may be running for office as well. So I think there's also some really important things that I thought I'd just add in about key things that you can do as an ER doctor to really be a public health champion. I think first and foremost, and I've tried to do this in the places where I've been, know your local public health leaders and the programs that your health department offers. I think until this pandemic, a lot of folks had no idea where their health department was, certainly did not know who their local health officer was, but your health department can really be a key partner in the work that you want to do in supporting your patients. I mean, when I was the health director in the city of Detroit, it was also, I guess, I'm a black cloud. It was during the hepatitis A outbreak. So I actually was able to work with the main hospitals in Detroit, and we actually implemented hepatitis A testing and vaccination in the emergency department. But those are relationships that should not just come when there are epidemics or pandemics. You should already have a relationship with your local and state, and quite frankly, federal public health leaders and your legislators, which is really, really important. Develop that relationship before you need something. Again, as someone who also has a lot of people reach out to them, it's nice to have just a relationship with someone and not have them come yelling and mad at me when they need something or they think that their funding has been cut. Which gets to my next point, which is really, I think it's important to understand the funding streams that are going on in your state and municipalities. Understand the budget cycle in your state or city. Like, there are sometimes opportunities that you can piggyback on. You should know what's happening. When you go and you talk to folks, know your key statistics. Have a specific ask. There's nothing worse than going in and not actually having anything to ask for or just complaining, but know what you want and know the projected impact of what your ask is. Another important thing, know the power of a story. Quite frankly, sometimes stories can be even more powerful than data. If you go into a legislator and you've got your randomized controlled trial, you come with 100 papers, they'll say, yeah, that's nice, put them over there in the corner. But you tell them a story about a patient, you go with your white coat on, you will be quite impactful. And that is, to be honest with you, really important. And it's sometimes how policy decisions get made. And then I think finally, realize that governmental public health is really committed. I mean, the public health leaders that I know in the state of Michigan, across the country, are just so incredibly committed, but they are quite, and have been for years, understaffed and underfunded. I think sometimes there's this perception that, why won't the state just fund me, or there's a grant, I need more money. Just understand that they can sometimes be, the funding is quite limited. As I said, some health departments didn't even have a single epidemiologist, which we all know how important that is now. So just recognize and understand the landscape of public health wherever you are. And I think that will actually help you when you're developing programs, when you're seeking funding, and quite frankly, when you're advocating for policies for your patients. So essentially, place, space, and racism and structural barriers are really the key drivers of health inequities, but they're not inevitable. I'm quite proud of the work that we did with the Racial Disparities Task Force, and I think it really shows that with intention and focus, you really can save lives. All of us, as I said, we know how to do this. We're uniquely suited because of our training, and all of you, because of what you're interested in, the fact that you're even here today, we can actually have an impact. And so to do that, it's really important that you know your governmental public health infrastructure, develop those relationships, and then just go and change the world. So thank you for having me. Really, really excited to be back with my family and friends in the emergency department. And I think I'll take some questions if there are any.
Thank you so much, Dr. Calderon. That was really inspirational. And I suspect we're going to have a whole bunch of questions into the chat. I think the first question that I'm sure is out there, because it has come up when we are all inspired, we would love to hear a little bit more about not just your path, but the path to being a policymaker, to someone who is able to call their epidemiologist and tell them what they need, because you know that many of us want to affect change, and as you said, there's lots of different places to do it. But tell us about the options to put ourselves on a path where we really can affect change at that level.
Yeah, absolutely. You know, 5-6 years ago, I don't even think I knew what the job is that I currently have. Didn't even know it existed. And so I think, you know, going back over in my career, I think I recommend all of you are just intentional in doing things that you're interested in. And I think I also strategically, I often found myself in rooms where I was the only doctor. And so I actually developed an expertise outside of medicine while I was still a practicing ER doctor and doing the medicine thing. And I think there came a time when my multiple skill sets became valuable, and I started learning more and more because I would just show up. I would just volunteer, like I said, get on committees, meet people, do things that you're interested in. And then, you know, opportunities I think often come, but I think the most important thing is to just keep doing things that you're excited and passionate about.
All right, we have a big question, so give me a second to read it. So our question is, at the height of the surge in LA, we saw a lot of disparities in resources by hospital with very little collaboration between hospitals or opportunities for transferring patients to hospitals with more capacity. I know LA is not unique in this sense. I would be curious from your perspective within the government, what are the barriers were to implementing policies that allow for more equitable distribution of resources between hospitals?
Right. You know, that was a challenge here in Michigan, particularly in the very beginning. I think, again, I mentioned our pandemic was concentrated in the metropolitan Detroit area in the very beginning. Those hospitals were becoming overwhelmed, but our hospitals in the more rural areas of Michigan were not. That said, we all knew that it could, just like that, change. And so we did have some transfers of patients and resources. We actually have regional kind of healthcare coalitions set up across the state, so they're used to working together and sharing resources. But it can be a challenge. And I'll be honest with you, I'll be quite frank with you. In Michigan, there can sometimes be this whole concept of us and them, where you have Southeast Michigan, particularly Detroit, but then you also have areas of Michigan, as you've all seen, I think Michigan's our entire pandemic has played out nationally for multiple reasons, but there are some parts of the state that don't have much diversity, are very rural. And so sometimes people can sometimes act like there's two different Michigans, which can be unfortunate, but it's a challenge. We did a lot of work on collaborating with our healthcare systems in the state.
All right, we have a question that goes to the left end of the spectrum, back to the bedside. So the question is, we in Newark have had access to monoclonal antibodies, but we had a lot of understandable mistrust from patients around it. So a lagging effect of medical racism and deep skepticism, particularly of anything that was considered new or experimental. So I think that the sort of logical follow-up question there is, at the bedside, what can we do? And I've heard people say that we want to increase trust, and then I've heard it really flipped and saying it's not that we need to increase trust, we need to increase trustworthiness. But I think both of those things are big goals for us at the bedside, and we'd love to hear your thoughts on how we do that.
You know, that's an important question. Again, I think we're still grappling with this in Michigan. That said, we have actually done some good work on decreasing that disparity. I think the last I looked at our data a couple of days ago, about 12% of our monoclonal antibody infusions were African Americans, which is similar to the proportion of African Americans in the state. So we've made some improvements there. It started off at like 3%. So I think it's important when you are at the bedside to share information, but also just ask what questions someone may have. And it's important that we not shame people for being hesitant or for having questions. I hate to even call people hesitant. It's just having a question. People care about their health. They don't want random things injected into them. And it's okay for people to have a question. I think coming to the conversation with your patient in that way can be very, very helpful.
Right. I think that it is respecting your time. Thank you so much. It was really wonderful to have you. I'm so glad that this could work out. And I discovered with Kabir that I just missed you at GW. I left right before you came, but unfortunately we didn't overlap. But thank you so much for this. This has been wonderful and inspirational, and we so appreciate it.
Thank you. It's been great to be back. Bye.
And we're going to wrap up here shortly. You're welcome to stay as long as you would like. So we're going to pull everything back in together. I'm going to turn it over to Maggie, and we are going to wrap this all up.
Thank you for joining us for the Consensus Conference, this exploration of social emergency medicine over the past 3 days of conference. As you know, this conference was in no way the beginning of social emergency medicine. People have recognized for a long time the role that healthcare professionals have needed to play in addressing the root causes of ill health and address manifestations of injustice and inequality. We've heard multiple times how the COVID pandemic has highlighted the health impacts of how where people live and work and their lived experience of discrimination and racism, and the importance of socioeconomic factors and the work that's been described here today.
Personally, I have learned so much from this conference and everyone involved. And if you missed any part, please remember that SAEM has all the recordings, and we will be sending out links to those recordings, so you will have them eventually. Our first keynote, Dr. Karen Rhodes, told us to ask big questions and to think outside the box. She told us to keep our eyes open for RFAs, which, if you don't know the term, RFA is a request for applications from a funding agency, which means that it has specific money behind it for your project. So keep your eyes open. And she taught us to recognize the importance of additional research training in being able to achieve our goals. Dr. Shaw's heartfelt keynote left me with many tools to help me fill my bucket. I hope you were there. And if you weren't, again, you can watch it. She quoted Cornel West. She said, "Justice is what love looks like in public." She reminded us to practice compassion with ourselves and with others. And she pointed us to a compassion exercise that we can all do and we can all share. And if you haven't seen it, you just Google compassion exercise. And I think you'll find it really helpful. She reminded us that our savior complex has the potential to hurt our souls and make us frustrated and withdrawn. And she reminded us that the process may be as important as the outcome. Dr. Khaldun inspired us with her example and provided examples of opportunities to contribute at different levels of engagement, the bedside, the ED, the community, and in policy and advocacy opportunities for social emergency medicine. It was inspirational to hear about how her work ensuring the collection of race and ethnicity data, addressing disparities in testing and vaccination, and ensuring equity for Black and Brown neighborhoods, given Detroit's history of redlining.
Our hope really is that today's conference pushes the field forward by pushing all of us.
For some, that may mean fanning a spark of an idea into a bigger project, or helping secure funding, or just growing a network of collaborators. If you would like to build on the momentum of this meeting, we've listed just a handful of the organizations and institutions who are engaged in work that's relevant to our conference proceedings, and you can feel free to reach out to stay involved. If you know of other groups, feel free to drop in the chat, reach out directly to us. And then also, as was previously mentioned, the SAEM Social Emergency and Population Health Interest Group will be continuing sessions like these throughout the academic year, including potentially informal career chats with leaders in our field. So we really encourage you all to stay in touch with each other, with everyone you've met in these breakout sessions, with the moderators. And again, if you have suggestions for how we can continue all this momentum, please feel free to reach out to Elizabeth, Maggie, and I directly. Our emails are listed on the slide.
Social emergency medicine is an acknowledgement that the brief touch point that happens in the emergency department usually does not affect the myriad forces acting upon a patient's health, but that it is possible through thoughtful training, advocacy, research, policy, and community engagement to mitigate some of the adverse forces that exist outside of, far from, and even generations before the ED visit. Social emergency medicine argues that health outcomes and the clinical care we provide can be improved with increased understanding of health-related social needs and social risks, that it is the job of every clinician to improve the health of the population, and that addressing these factors, both within and outside of clinical care, may often be possible and warranted. This is not to suggest that it is the job of the individual clinician to fix all of the patient's social problems during a visit, but that it is the job of our field to continuously push ourselves and our communities and our world to do better for everyone.
Social emergency medicine is caring about the whole person with a goal of understanding and dismantling the structural factors that contribute to poor health and creating and promoting systems that foster equity and emotional, mental, and physical well-being. Thank you all for joining us, and thank you for all that you do. What you do matters, and hopefully this conference has strengthened what we can do collectively. We look forward to hearing from you over the coming months and years as this community continues to grow. Thank you again.